Check, mic check, check. Good evening all. This is Trupti Pati. Check it.
इथून आहे इथून. चार्जिंगचं सध्या एवढं चेक करायचं.
हो 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 सगळे ह्याच लॅपटॉप.
आणि सर त्यामध्ये काही व्हिडिओ आहेत की फक्त पीपीटीच
व्हिडिओ
पीपीटी मध्येच व्हिडिओ आहेत काही माझे छोटे मेजर काही नाही आहे.
त्याच्यामध्ये एक रीतच विषय.
Yes, sir. We are waiting from. Fourth floor. Fourth floor. येऊ द्या काय हरकत नाही. हो या या नो सर लॅपटॉप तुम्ही ऑन पेन ड्राईव्ह
Good evening, all. I, Ms. Trupti Patil, host for today's CME. It's my absolute pleasure to extend a hearty welcome to each one of you, respected speakers, moderators, delegates who has joined in person and online for CME on Pelvic Floor Disorders, organized by Kaizen Gastrocare GI Physiology, unit in collaboration with Pune Surgical Society and Association of Colorectal Surgeons of India. I request to Dr. Samrat Jankar, Director of Kaizen Gastrocare, to come on the dais to welcome our delegates and address today's topic to give brief thought process behind this program. Dr. Samrat Jankar, please welcome on the dais.
Uh, Good evening, everyone. It's my pleasure to welcome you all for today's CME Pelvic Floor Disorder. It is organized by Kaizen Gastrocare in collaboration with Accuracy Association of Colorectal Surgeons of India and Pune Surgical Society. Pelvic floor disorder, it encompasses a lot of spectrum of disease condition. But for this program, having a short duration of 2 to 3 hours, we will focus mainly for defecation disorder, which is the main problem for all gastroenterologists, colorectal surgeon, and everyone. In that, we are going to have a session which will give a holistic approach towards managing dyssynergic defecation in pelvic floor disorder. We are honored to have esteemed moderator, Dr. Pradeep Sharma sir, President of ACRSI, and Dr. Bharat Dixit sir, President of PSS, to guide today's session. We also welcome excellent faculty, panel of faculty speakers are available for today's this topic, who Dr. Sanjay Saunke sir, a senior gastroenterologist, we will enlighten on 10 commandment of use of laxative based on current guideline. Dr. Darshan Shah is a senior radiologist who will talk on MR defecogram. Dr. Rupali, we will give an insight on biofeedback therapy, and Dr. Dipti Guduru, we will be giving a role of physiotherapist in pelvic floor disorder. Rai Patankar sir, he will talk on the when to do surgery, how to perform, and most important is when should not attempt for the surgery. We extend warm welcome to all our delegates who are medical gastroenterologists, colorectal surgeon, physiologists, and physiotherapists. Many are there on online already. It is crossing 150 number, and also in-house. We will not waste much time, and I welcome all of you to take an opportunity to interact with all the faculty and discuss and have clarified about the doubt of this program. So I will hand over mic to Trupti to further proceed for the program.
Thank you, Dr. Samrat. Now, I would like to call our today's both the moderators, respected Dr. Pradeep Sharma sir and Dr. Bharat Dixit sir, to occupy the dais. Dr. Pradeep Sharma is highly experienced surgeon specializing in gastrointestinal, colorectal, laparoscopic, endocrine, and cancer surgeries. He is currently a senior consultant at Jahangir Hospital, Pune, and visiting consultant at Ruby Hall Clinic, Inamdar Multi-Speciality Hospital, and Motherhood Hospital, Pune. Dr. Sharma is the president of the Association of Colon and Rectal Surgeons of India. Dr. Bharat Dixit is well-known laparoscopic surgeon at Pune Hospital and Research Center. With 29 years of experience in general and laparoscopic surgery, he's worked across multiple cities in India, handling complex cases. Specialty include laparoscopic surgery, varicose vein surgery, and trauma management. Dr. Dixit is currently the president of Pune Surgical Society. Thank you.
Our first speaker for today, I'd like to invite is Dr. Sarunke. He's going to speak about the choices of laxatives, when to use what, which I think is the backbone of surgical practice today. Dr. Sarunke. A brief introduction of Dr. Sarunke by Trupti.
Dr. Sanjay Salunke is highly experienced gastroenterologist in Kharadi with 35 years of expertise. He is a consultant at Asha Clinics specializing in diseases of the digestive system, liver and pancreas. Dr. Salunke focus on accurate diagnosis, targeted investigation, and protocol-based long-term care. He has a special interest in neurogastroenterology, particularly GI motility. Dr. Salunke recently established the GI motility division at Ruby Hall Clinic, Vanori, and Jahangir Hospital. Please, sir. Thanks.
Yeah, good evening. Team Kaizen Gastrocare, Pune Surgical Society, and the Colorectal Surgeons Association. Thank you for giving me this opportunity. Can we go live? Yeah, thank you so much. So, without much ado, how to choose laxatives according to the current guidelines, but I think I'm going to make a little brief introduction. So, an outline of my discussion will be, first of all, why do we have sphincters and what's the difference between the two sphincters? If you want to establish a dream colorectal unit, what would you think would be the standard of care in the world? Slow transit is constipation or otherwise. So we should know a little bit more about what colon transit is. In general practice, what we need to know is how to take a good history and examination. Then there are three phenotypes of constipation: normal, dyssynergia, and slow transit, which we will now talk about. And laxatives: when to start, how to stop. So let's discuss why sphincters. How did we get sphincters in the first place? So when life was in the sea, the fish had a bladder, but that bladder was just to float and to maintain balance. When life moved on to land, what happened was that we needed to lose our urea, and so we developed the loop of Henle, and the kidneys started developing, and these kidneys got attached to the bladder. The balance which the bladder was giving, we did away with, and then the bladder became a muscular organ for storage for urine. So that's how we got our bladder in the first place. 2019, there was this beautiful article that the evolution of the urinary bladder as a storage organ was actually caused because we had to protect ourselves. And it was the selection pressure for the first land animals. And this was figured out by computation simulation. And so the sphincters actually gave us a survival advantage. How? If you would have continued to leak urine all along, then it would be, you would be an easy target for the predator. And we had to control it so that we didn't want to leave any scent behind. And this bladder was then controlled by the higher centers. And so we could control it even though we were exerting, coughing, or straining. What's the difference between the bladder and the colon? The Barrington reflexes. In urology, if you go, you need reflexes. Like before you want this meeting started, would you want to go to the, you want to relieve yourself? No, I'm fine. I can hold on for a bit more. I think I could go if I had a chance, but I think I must go now. So you could decide when you want to pass urine. It's not the same for stools. So these are the reflexes which decide these actions. So we can control at a local level, at a spinal level, and at a higher center level, because of which we have good continence and we can decide when to pass urine. Not so with stools. So we empty when it's convenient, else we can defer to even if you are at full capacity. In animals, there is social defecation. They don't eat where they defecate. So there is this social defecation and they can decide where to do what. More important for survival, in case in this picture, even if one animal passes flatus, that is end game. So we need to control in such a way that for 10 to 15 seconds, if we have good control, whatever was there in the rectum goes back into the sigmoid. And we can not only at the full state, but even if the bladder is empty, the bladder can be emptied even when it's nearly empty, and it can be emptied efficiently and completely. Lots of differences between the bladder and the rectum. Enter Newton. We knew that the apple fell on his head, but it was not solids alone that Newton was thinking of. Liquids. How do liquids flow? So they say Newtonian liquids flow in such a way that it will go by shear pressure, but if fluids become thick, this is similar to stools, Bristol 4, that means semi-solid stools, but stools can be thicker, they can be more formed, or they can be thinner. And we need to have the rectum to control all this. You may also have a problem in case you have liquid stools in the rectum and gas, and now you wish to pass only the gas. So we have such a fine control, and the job for the rectum is much different than for the urine, and we can sense and push back what we don't want to pass and just pass the rest. But where does the stools then go to? It doesn't stay in the rectum. The rectum is not the storage organ. It goes back to the sigmoid. If you want to set up a world-class colon physiology center, what would you look for? So this is how the colon works. We have 10 liters coming to the colon, but only 200 grams stools is actually made out of it, because a lot of to and fro activities going on, trying to reabsorb all the water. And amongst this is a high pressure contraction, which happens 5 to 6 times a day, which is really high pressure to gather all the stools, bringing it down. So what you see on the top is something like what the kidney does, reabsorb water. And what you see below is now the colon is behaving like the ureter. And these contractions can start anywhere in the colon, but they will end in the descending and the sigmoid. What happens in the sigmoid is that there are pressure waves which are gradually increasing in strength, and they are coming down to the rectosigmoid sphincter, which is a notional sphincter of O'Brien, which is just a high pressure zone. What's happening in the rectum at the same time is it is a braking mechanism, so it is pushing everything back. So between the sigmoid, rectosigmoid, and the rectum are what we can say the sphincters, which are helping us to get control. The puborectalis is our voluntary control. Now you get the pressure to pass stools. So when you get the pressure, what actually happens is a high pressure contraction is pushing everything down to the rectosigmoid, and each subsequent contraction is carrying whatever is left behind, so that all the stools are now reaching the sigmoid. And if you don't get this call to stool, that means pressure ala. If it doesn't happen, then you are going to get slow transit constipation. So this is what we know as wake and go reflex, eat and go reflex. Please remember this because it is going to come later again. There is a lot that can be said about the sensitivity of the anus, which is a separate discussion altogether. But just I'm going to leave you with the message that plenty of receptors are there in the anus to do our job of discrimination. I'll move back to the rectum. The rectum is now sensing. How do we assess the sensation in the rectum? We use a system called barostat. So in case the barostat is put in the rectum, there are two sensors at the front and back of the balloon and two sensors in the anal canal. And if I blow up the pressure wave, it will look like this. You're inflating the balloon, and there is a rise in pressure, which is followed by a fall in volume, which is actually a contraction. You may or may not make this out. This is the rectal contractile response, the first thing that you need to pass stools. This is also the pressure that you feel. Now you need to go. This is the call to stool that you get. As stools collects in the rectal pressure rises, the anal pressure drops, and this is what we know as the rectoanal inhibitory response. Now the play starts between the rectum and the spine. There are local wall reflexes which excite the internal sphincter and inhibit it, and there are autonomic reflexes which form the rectoanal excitatory reflex. Everything is between a want to empty and I don't want to empty. So these reflexes are only in research. We don't have the tools to check this. But the higher centers are telling you that this is not the right time to go and pass stools. So what happens is you start getting contractions which are high amplitude contractions, but they're going backward. And so there are orally directed high amplitude contractions which we can measure, which tell you this is not the right time to pass stools. And they are cyclical. But if it is the right time to go, how will you test the rectum, which is motor? So you have a Physiobionics device in which there are pressure sensors in the front, pressure sensors at the back. And when you push to pass motions, you have a pressure wave which is pushing outward, whereas from behind the balloon is being pushed, and there is a delta wave which is efficient emptying of the rectum. In case the rectum doesn't empty completely, this is dyssynergic defecation in which there is a flat wave, and patients with incontinence have a very small contraction resulting in a very quick evacuation. The same balloon, if you pass barium and see it on an X-ray, will look like this. The new point about this Physiobionics device is that when you are passing stools out, it measures the pressure as the balloon is passing through the anal sphincter. So you have real-time anal sphincter measurements till it drops out in the commode. And in case there is a weak sphincter, it needs very little inflation to pass out. This balloon can also detect angulation, and this is the device bending, the straightening, as well as dyssynergic defecation. You can even add a camera to the tip of the Physiobionics balloon, and it will show you what we know as piles are actually anorectal cushions. And when we want to pass flatus, you can actually see these anorectal cushions opening to show continence of flatus. So everything in a high-tech center can be seen real time. What is slow transit? Is it always that you have slow transit when you are talking of constipation? So there is a test which we do, which is the colon transit time, and it is spread out over 5 days. So we give 12 capsules, and each capsule contains 5 markers. So we have 60 markers. These are medically safe, and the shape can be seen very easily on X-ray. You take 4 capsules at a time on 0 hour, 12 hours later, and 12 hours after that. So you have taken 4, 4, 4, and then you're telling the patient not to take any laxatives after that till all the X-rays are done. You will ask the patient, go to any X-ray center, it has to be only a digital center close to your home, and ask him for a plain X-ray abdomen pelvis lying down. The technician asks, ye kya hai? You say KUB. I want the diaphragm and I want the pelvis. So you do an X-ray at 36 hours and you do an X-ray at 60 hours, and this is the end of the test unless there is a slow transit. When you see the X-ray, you drop a line till the L5 and the sacral spine and the iliac crest. So you have divided the X-ray into 3 parts. There is the right, left, and the pelvic part of the X-ray. And in Indian studies, Uday Ghoshal has shown that 30 markers or less at 36 hours, 14 markers at less at 60 hours is normal colon transit. So this is a X-ray which was sent to me from Bhigwan. So you can imagine, I just give him the capsule, then he goes. And from his village, he sends me the X-ray, from which I can tell him that this is normal transit, 30 markers at 36 hours, and 14 markers and less at 60 hours. In this X-ray, there were very few markers even in the first X-ray. But you can have an X-ray like this, which is slow transit because there are larger number of markers, and this will be slow transit constipation. And if all the markers are piled in the pelvis, then this is the pelvic floor dyssynergia. You can also have X-rays limited themselves to the right, to the left, and in the pelvis, but this is a subject for another discussion. How do you take an history? in a patient with constipation. You can find all these things which I told you of technology just by history. So how do you get to there? So I have compiled a paper from 2013. This is the Asian guidelines, the Indian paper at 2018. They are the Seoul guidelines 2022, which are the latest for Asia. And there are some guidelines which have come from the Rome, because Rome used to say, ask the history for the last 6 months, but now they understand that you can have occasional constipation which also needs to be recognized as an entity. So these 4 guidelines I have now taken together. Initially, you will always want to find out whether the patient has alarm signs and he needs to go for a colonoscopy. So this, everybody knows the typical history in which you would not consider this patient as a functional, and you would also rule out rectal prolapse on history alone. Now, if you want to examine a patient, what are the questions you'll ask? The first question is, what is normal for you? There are people who go 3 times in a day, which is normal for them. There are some people who will go once in 3 days, which is normal for them, and then that becomes the benchmark for their treatment. You would also then ask, what is your reflex? When do you get the urge to go to the toilet? Do you go when do you wait and go? I showed you that reflex which can be elicited. So do you wake and go? Do you eat and go? Or you go with all the meals? So you need to know when is the reflex, because from there all your treatment is going to start. So do you then respond to that reflex? We get mothers who tell me that मेरे बच्चे का दवा बनाना है, उसको स्कूल को भेजना है. So everything is done, then after that I go and sit on the pot. But by that time, the high amplitude peristaltic contraction has taken the stool back to the sigmoid. What is going to come out now? So you need to respond. Do you squat when you pass motions? And this is a typical example of a squatty potty, where you have pads which allows the friction not to displace your legs, as well as you can have an erect posture so that you can bear down properly to open the anorectal angle. Can you initiate defecation right away? You go, you respond, you sit, and do you get stools? Very important, because those people who do not initiate are patients of Rupali. How much time does it get you to get done? Less than 5 minutes or more? And some questions which probably take the patients to the surgeons. Do you feel incomplete? Is there a sense of anorectal blockage? And do you need maneuvers to assess defecation? We'll talk a little bit more about the Bristol score. And to complete the list of 10, medication and digital rectal examination, these are the 10 questions you're going to find with which you're going to get the diagnosis of constipation. So to look at the Bristol score, this is my table where I do my consultations, and many doctors have their family picture on the table, but in gastroenterology's rooms, we have pictures like this, which is actually one of our tools. This is the Bristol stool score, in which type 1 stools, very hard, transit time is 100 hours, and very loose stools, the transit time is 10 hours. So just seeing the picture of stools tells you what it could be the colon transit time. And this is a pediatric scale in which they have suggested that the parent should look at the common shape of the child's stool. So you can easily use this tip and say, commonly, where do you put your stools? So in case all your questions are on the left of the screen and a little bit of the top, and the Bristol score is not very bad, you're looking at a patient who's having normal transit constipation. In case you may not be going daily, you may be sitting for very long, but your stools are very, very hard, you're looking at a patient who's likely to have slow transit constipation. But on the other hand, if all your questions are on the other side of the screen, and there is a lot of maneuvers that the patient does, and the digital rectal examination is going to show some abnormality, you're looking at a patient who is having dyssynergic defecation. So what is the digital rectal examination? Now, this has been enshrined by the Indian Society of Gastroenterology as a protocol in which you are first inspecting and making sure that you have got all the anatomy right. You are eliciting the sacral reflex by touching the skin and seeing that the sacral innervation is intact. After which you pass your finger and see the thickness of the puborectalis muscle, and then you ask the patient to contract the sphincter, and what you will see is the sphincter is moving towards the abdominal wall, and in case you bear down, then you can see the sphincter moving down, and the hand on the abdomen is actually making out that you are really bearing down. This is the way to find out the reflex. You take out the finger and look for blood on the examining finger. The surgeons in the hall know everything, but this has now become a part of Indian Society of Gastroenterology. Normal transit constipation, what is it? It is not constipation at all. It actually means that this patient may be having lactose malabsorption, or he may not be tolerating wheat. It can be a part of post-infectious change in bowel habit. He may not be tolerating adrak, lasan, pyaz. These are all the contents of these foods are FODMAP. Indians are vegetarians. They have a different gut microbiota, and they also has a role in developing symptoms of irritable bowel syndrome. But also this can be a psychological state in which anal retentive behavior, which is seen in children or it is seen in adults, the typical A-type personality who comes to your OPD, I have constipation, I've tried everything. And he's the person who probably will demand medication, but you might find that there is nothing in him, but it's just his psychological state. Dyssynergic defecation is going to be taken by the next two speakers, so I'm not going to dwell on that. And in slow transit constipation, you know exactly what it is. But what as gastroenterologists, the extra that we do in case we need to find that out, you need to know that there is the onus nucleus which is at T12L1, in which the innervation is not only somatic but it is also autonomic. And that's what makes it very unique, because since it has both the innervations, your autonomic functions are also controlled through the spinal cord. And so your higher functions can influence this. The reason I'm eliciting this is that in a patient of slow transit constipation, you need to see the spine in great detail. So what would you look at? A few things. Brainstem lesions could cause this. Stroke syndromes you need to know. Patients with multiple sclerosis, they could also present early with this. And high CNS lesions, obviously, they are actually far gone. Cauda equina lesions can also cause slow transit constipation. There are drugs for neurological conditions which can cause slow transit constipation. Very important to know Parkinson's disease. 2 years before Parkinson's, patients start getting constipation. The incidence is very high. And we have very typical findings on anorectal manometry, which I won't dwell on at the moment. But the medication given for Parkinson's slows down the gut as well as the stomach and the colon, and you are actually worsening the constipation. So there is a futile attempt of the neurologist who is trying to give stronger and stronger medication, whereas if you give strong laxatives early in this constipation, you will prevent the stasis from happening. So you probably might help your neurologist by choosing to use stronger laxatives in this slow transit constipation. You may even tell your neurologist that I have diagnosed the Parkinson's for you. Parkinson's basically starts as a peripheral disease, and what has been found is that there is an immunohistochemical marker which can be seen in the colon biopsies of patients who develop Parkinson's later. So if you have done a colonoscopy and you have found slow transit constipation, there may be a day when which you might take blind biopsies and you send it for this immunohistochemical marker, and you might find that this person develops Parkinson's later. So these are just the outliers of slow transit constipation. How to choose laxatives and how to customize them? There is a decision tree. The patient has to participate. You can't write a prescription and go. It doesn't happen. You remove all the factors that you can, which means you look at his prescription list. Hematinics, acidity की दवाई, respiratory medications, pain medications, oxybutynin for the bladder, antidepressants, and medications for blood pressure. You need to go through this all because you will find that these are confounders in the constipation. You need to increase fiber. So we tell how much fiber, the dietitian says increase it to so much, but you need to remember that you need to increase slowly, 3 grams to 4 grams per week, otherwise these patients get bloating. Now the juice of the prescription, what are the medications you need to give? In the guidelines, this part comes right at the bottom, but it is to be prescribed right at the top. So if you have hard stools at the start, mineral oil as lubricant, and in those patients who bloat and constipate, remember to add probiotics right at the start. You have fiber, which I'm not going to talk too much upon. We know that lactulose is a very safe laxative, which is nowadays standard of care, and milk of magnesia has gone out because it has a renal toxicity. But in case it is used, it has to be given in this dose. PEG is again standard of care. Remember that those medications which contain sorbitol, they act as laxatives. Sorbitol can also get absorbed into the colonocytes, and there is no way for it to come out. And that's why you can have sorbitol toxicity, but that's a different topic. Those people who need sorbitol as a laxative one time, this is the dose that is given to them. There are stool softeners which are used in this dose. Academics, nowadays I don't think it is standard of care anywhere. And then come to the big daddy of all prescriptions, the stronger laxatives. So we know this is a prescription, this is a drug which is abused. So these are all anthraquinone glycosides and phenolphthalein, Senna and Cascara. About this, there is a statement which reminded me of Baba Ramdev. The Canadian healthcare has actually developed guidelines for preparing a product license application and labels, something which Patanjali will never do. But this is what is standard of care when you want to prescribe Senna. They are doing it abroad. We know Gerbiza and we know picosulfate. Both are converted to the same active ingredient. So we cannot change from bisacodyl to picosulfate because they are in the same class. Both are prodrugs. The dose is, everyone knows, but just as a repetition, bisacodyl 5 to 15 milligrams and sodium picosulfate 5 to 10 milligrams, half dose for less than 5 years. The prokinetics, we knew that cisapride and tegaserod went away because they had cardiac toxicity. So this drug binds to 5-HT4 and it binds to another HERG potassium, and that's where the toxicity is. Prucalopride binds 150 times more to the 5-HT4 and that makes it safe. I don't know how much it binds to HERGK, but this is why it is safe and you have lesser cardiac side effects at 1 to 2 milligrams a day. Then the stronger laxatives are called secretagogues. So lubiprostone is a calcium channel activator, calcium and bicarbonate, linaclotide, not yet in Indian market. And ilobixibat has just entered the market. It works on creating a lot of secretions in the right colon, which will then move everything to the left. The only problem is you need to give it on an empty stomach 1 hour before dinner. So now, what to do with the people who are only having short-term constipation? The guideline says use the stronger ones right away and then the other ones. And if you have constipation type of IBS, then it's bisacodyl. But pain predominant IBS short-term, you would use polyethylene glycol. How to stop laxatives? Why stop them? So this is a paper which is coming from the UK, in which the findings support that you can have more falls in patients who use laxatives. Though these patients are using everything to put calcium back into their bones, it is not working because the laxatives are removing it all the time. And so you need to keep looking at their prescription and trying to find out why they are likely to be at a higher risk of fall. The longest study is 40 years, and they found that Senna, of all things, is the drug which would be safe, which actually is a very contentious statement to make. So what do you tell people who are constantly using churans? So this is an animal study which I found in which they gave the same churan to rats. And what happened was that this study tells us more about what a cathartic colon looks like, including melanosis coli. But they gave these rhubarb drugs in a dose by which they reached a point where the rat started getting a diarrhea, and they kept it at that dose for some time. And after that, the diarrhea stopped. Then they increased it by another 200 micrograms. So they created tachyphylaxis in the rat. And what they found was rats get used to Senna laxatives within 1 to 3 months. So looking at the rat's life, in 1 month the rat gets used to Senna. Now you can extrapolate to humans. So you are likely to get habituated to Senna laxatives. How do you stop them? No way, there are no guidelines. But what I found in the UK was they have clinical knowledge summaries for patients, so the patients can go and help themselves. You came asking me for a laxative. Now you find out how you're going to get off it. The doctor may not be able to tell you. So in 2 to 4 weeks, you're going to be fine, and you should start trying to de-escalate, and you should wean in such a way that which you don't need a rescue therapy. And begin by removing the stimulant laxative first. So you remove the prucalopride. At that price, you may need to increase the dose of PEG so that you can get a good response. And it might take months for all this to get over. Relapses are common. And those people who are on drugs like pregabalin may not be able to get off. And those people who have already a slow colon may not be able to de-escalate. How to prevent this? So here AI comes into the management of preventing constipation. From China, they found that age, anxiety, calcium, exercise, certain things which we never associated with constipation. These are things which they need to be vigilant about early in the management of their diabetes so that they will not get constipation later. And to prevent constipation in diabetics, there might be a day when nomograms which will be driven by AI will tell the doctors how they will not get permanently into slow transit constipation. Thank you so much for this privilege.
Broad overview of all the aspect of constipation.
Thank you
Okay?
so much.
Thank you. Yeah. Now, I invite the next speaker. Next speaker is Dr. Darshan Shah. I request Dr. Trupti Patil to introduce Dr. Darshan Shah.
Thank you, sir. Dr. Darshan Shah. Sir is a well-known senior radiologist at Star Imaging with 15 years of experience, specializing in GI and head and neck imaging. He is highly skilled in MRI defecography, and MRI fistula studies with a special interest in body imaging. I request to Dr. Darshan Shah, please come on the dais.
This one, right?
Thank you so much, and I'm extremely grateful for giving this opportunity and be here amongst the clinicians. I get always like these interactions because I get a lot to learn. Okay. So, based on what Samrat had sent me, there is a lot of apprehension which is involved in understanding a defecogram or even interpreting what the radiologist is trying to say, which is very obvious, and you'll come to know why the reason it is happening. So, as a part of this talk, I like to focus on the outline, what basically is an MR defecogram, okay, indications why the patients come to a radiology department, and what is the disease prevalence. The technique, it may not be very relevant to this population, but I'll still just like to brief on what exactly is done and how it is done. Reporting guidelines. Now, sir has already spoken regarding why everything should be guideline based. And hence, I'll just try to brief on the protocol which comes to like imaging a patient with the appropriate guidelines and the reporting guidelines as well. We'll see a few cases and then the take home message. Now, can just someone help me to get a pointer here? Okay. So, to begin with, defecogram, it began in the older era with a conventional X-ray defecogram. The issue being that we are not actually able to see the pelvic diaphragm directly. And we may not be able to evaluate all the three compartments together. But still, it was best tool which was available at that given point of time. And we could evaluate abnormalities in the lumen of the rectum, but not anything which is going outside. What MR gives us as an advantage is two things. It gives us morphology, it gives us function, both coming together. And it is, as the name suggests, it's a dynamic study wherein the patient, lot of patient cooperation is required during this particular procedure. I think this is the only procedure in radiology imaging where it's absolutely patient dependent and not radiology or technician dependent. And what it allows us to evaluate at the same time is all the three compartments of the pelvis, the anterior compartment, the middle and the posterior compartment. Now the issue with a study like this or a patient like this is that because there is varying degrees of affection of the compartments, the patient could either present to a gynecologist or a urologist or a surgeon. And because the population to which the patient is going to may not be very well aware with what is happening in the other compartments, it could be possible that the clinician is trying to treat one single compartment. But we need to understand that the pelvic as a diaphragm is a dynamic structure, it's a single structure. And if one compartment is affected, it is quite possible that to some extent there could be affection of the other compartment as well. MR beautifully depicts abnormalities corresponding to all the three compartments. Indications when a patient usually comes to a radiology department, most common could be an obstructed defecation syndrome or something, patient complaining of chronic constipation, or it could be a pelvic organ prolapse coming from a gynecologist or even from a proctologist who says that there is rectal prolapse which is coming there. Sometimes it could be for stress urinary incontinence where the urologist is interested in seeing the hypermobility of the urethra, sometimes for fecal incontinence as well. But you need to understand that the prevalence of the disease which is there in the population, it is 50% of the multiparous women who are beyond the age of 50, they are likely to be affected to some extent in some compartment of the pelvis, which is huge. 50% of patients who are multiparous beyond the age of 50. And so it is quite possible. Unfortunately, the disease, it evolves slowly over a period of time, and a patient might think, this is part and parcel of life. And they may not present to the clinician unless and until there is some catastrophic event or patient realizes there is some issue with the urination or something is popping out in the perineum. So what MR defecogram, there are no contraindications per se to an MR defecogram except for standard contraindications for any other MRI. And the gross issue with the procedure for me as a radiologist is a failed procedure because the patient has not been able to comprehend what exactly is to be done and is unable to provide adequate strain while performing the defecation phase. You might not realize this of a failed procedure, but sometimes when I tell a patient on an ultrasound table to hold his or her breath, they are not able to do so. They don't understand, they don't comprehend what exactly they are supposed to do. When I tell them to hold a breath, they'll keep on breathing in, breathing out, trying to hold your breath either during inhalation or exhalation. So for an MR defecogram study to be successful, it is absolutely essential for the patient to comprehend what is to be done. So study time may be 10 minutes, but me as a radiologist or the technician or the sister or the staff, they have to train the patient to understand what exactly they are supposed to do during the procedure. Now, these are prerequisites, these are standard guidelines which have come up over a period of time through a working group. This working group has involved a whole lot of clinicians, right from urologists to gynecologists to surgeons, colorectal surgeons and radiologists. So they have tried to come up with a comprehensive guideline to how to do a study and how to present it in a reported format. There are some other technical indications which we will skip in interest of time. We can skip this as well. But what I like to mention is what MR defecogram is doing. It is allowing us to evaluate the dynamic nature of the pelvis. Okay, the pelvic diaphragm is somewhat like a thoracic diaphragm. Only thing, it is not moving continuously upwards and downwards, but it's a musculotendinous structure and it is bound to move with increased intra-abdominal pressure. It is meant to happen so. And typically the phase or the studies which would involve in an MR defecogram would be a resting phase where the patient is lying down breathing comfortably, a squeeze phase wherein the patient needs to hold the perineum tight and move it upwards towards the pelvis in an attempt to avoid passing stools, the strain phase or the Valsalva phase where the patient is increasing the intra-abdominal pressure but not allowing passage of or not emptying the rectum, and finally the defecation phase. The guideline also mentions the duration for which each phase is to be performed. Typically the squeeze and strain is, it would be for the respiratory breath hold duration of the patient. 20 to 25 seconds is what you can expect a population to hold their breath for. But for defecation, they have typically mentioned for a study to say, for me to say that it is not being successful, I need to have at least 3 attempts, wherein each attempt is lasting for up to 50 seconds. The very important guideline which has come up over a period of time, if the patient is unable to empty the rectum on table, he or she goes to the washroom, they may require a digital splinting of the perineum, empty the rectum and then come back on the table, and I need to repeat the strain and Valsalva phase during that particular point of time to assess what was not seen during defecation, whether it is really there or not. We'll come to see these through examples. These are a few guidelines which the patient may probably require some support below the knee so that the knees are elevated. There also has to be support at the foot end of the patient, because unless and until that is provided, the strain effort of the patient is going to be inadequate. So this is one particular study, as I've mentioned, it is completely patient dependent. So the entire effort while doing, or rather than before the study, has to be towards training the patient of what all the patient has to do in the MR gantry. This training may take up to 50 to 20 minutes for the patient to comprehend what exactly is to be done during the procedure. So on recommendations, what as a radiologist, what the guidelines has been provided, what I need to report during an MR defecogram is the patient position. There are some centers which are available, not in India, wherein the patient can actually, the MR can be done with the patient in the standing or the squatting position. There is another guideline of the amount of rectal jelly which has to be used to distend the rectum. If I initially directly go to 200 to 300 cc of rectal jelly, the rectum gets abnormally distended and the patient may not be able to attempt evacuation of rectum during that particular point of time. So simple guideline is I start with 50-60 cc and ask the patient, are you having a sense or an urge of the distended rectum and a desire to defecate? That is good enough. I need not go directly towards 200 or 250 cc to begin with. Following this, the other important feature that as a radiologist I need to mention is effort of the patient during study, and this would be very well be visualized with movement of the anterior abdominal wall during straining and during defecation. If I'm not able to see movement of that particular anterior abdominal wall during straining and defecation, I'm not able to see movement of the pelvic floor, it basically means that patient is not taking good effort to evacuate the rectum. So these are the standard measurements which have come up over a period of time. Sir has already mentioned to me that, they are probably trying to get rid of use of various lines which are there in the pelvis. But as of now, the guidelines do mention that I need to come up with these, and these guidelines are more dynamic. So maybe over a period of time, we may not be required to give all the measurements in the report, and it could probably be more dynamic and just mention what all is going on as a part of the anal canal, the rectum, the movement of the perineum and the pelvic floor. So what I need to mention is different lines. We'll just come to that in the next slide. And the presence or absence of cul-de-sac hernias, presence or absence of abnormal inferior rectal or perineal descent, presence or absence of a rectocele, rectal intussusception, and something which is mentioned is the change in the anorectal angle. The significance of that, I'll just let you know. So the apprehension, I'm just going to end it right away, what these lines and measurements are. It is very simple. PC line, it corresponds to the pubococcygeal line. So basically it's a line which joins the inferior margin of the pubic symphysis to the last coccygeal articulation. It's not the tip of the coccyx, it's the last coccygeal articulation. It basically reflects the position of the pelvic floor when the patient is at rest or even during the dynamic stage. The other is the H line, that corresponds to the hiatus line. It's the hiatus of the pelvis which is bound by the puborectalis ligament on either side and posteriorly, and anteriorly by the inferior margin of the pubic symphysis. Then we have the M line. It basically indicates the position of the anorectal junction in relation to the pubococcygeal line. Up to 1 to 2 centimeters, if it's a perpendicular which is drawn from the anorectal junction, which is the junction between the posterior margin of the rectum and the long axis of the anal canal. That's the anorectal angle. And I draw a perpendicular from this, the point of this angle, to the pubococcygeal line, that is termed as the M line. It basically gives an indicator what is the degree of variation of the position of the anorectal junction in relation to the pubococcygeal line during the dynamic MR defecogram study. And that's lastly the anorectal angle. I've already mentioned it's an angle between the line drawn along the long axis of the posterior wall of the rectum and the long axis of the anal canal. Now, see, in spite of there being guidelines, there is a lot of variation in the normal anatomical landmarks as well. So sometimes it is possible that the M line or the anorectal junction, it would lie above the pubococcygeal line. But if it lies within 2 centimeters below the pubococcygeal line, it is a normal anatomic variation and we need not bother for it. So what MR defecogram would help us identify is presence or absence of descent from the anterior, the middle and the posterior compartment, and we would give corresponding descriptions in terms of cystoceles or abnormal vaginal descents or abnormal uterine descents, abnormal anorectal or perineal descents, and presence or absence of any cul-de-sac hernias. Okay, so before coming to what is abnormal while doing an MR defecogram, let us identify what is normal. Okay, so that's the resting phase, that's the squeeze phase, and the strain and defecation phase performed as a single sequence. So if you see during the resting phase, that's the anorectal angle, the anal canal is closed, the anorectal angle is somewhere close to 90 degrees. What happens during the squeeze phase is that the puborectalis sling is an horizontal obliquely oriented sling. It moves more towards the pubic symphysis, and hence we see there is reduction in the anorectal angle. So the anorectal angle becomes more acute. And what happens during strain and what is expected to happen during strain and defecation phase is that the rectum needs to come more in line with the anal canal. For that to happen, the angle should actually increase than what it was during the resting phase. So it needs to become obtuse. So if this was 90 degrees, the squeeze would be reduced to say varying degrees somewhere between 70 to 60 degrees. And during strain and defecation, what would happen? It would increase beyond 90 degrees going towards 100, 120 or 130 degrees. Unfortunately, we don't know what is normal. So best is to compare it to a patient from the resting phase to the squeeze phase and then towards the strain and defecation phase. So this is just an example. Okay, so this is what is happening during a dynamic phase. What we see, there is inferior displacement of the pelvic floor. There is inferior normal descent of the bladder, the prostate, the uterus if it's a female patient, or a vaginal vault which is happening, because the pelvic floor is a elastic structure, it's not a rigid structure. So increase in the intra-abdominal pressure, you are going to see that descent. What you also see, okay, just look at the movement of the anterior abdominal wall. It basically means that the patient is making a good effort. Sir has already mentioned, you keep while examining, you keep the hand on the anterior abdominal wall. It will give us a good grade of what effort the patient is putting. So we can actually see the movement of the anterior abdominal wall when this is happening. And what other thing is happening is that there is increase in the anorectal angle, which is very essential, because if this angle it increase, the rectum is lying more in line with the anal canal and is more easy for the rectal contents to pass beyond the anal canal. So what happens during dysynergetic defecation? Okay, so during rest we expect the angle to be somewhere close to 90. It may not necessarily be 90. It could sometimes be 70, it could be 75, it could be 100 as well for patient to patient. What happens during squeeze phase? There is reduction in the anorectal angle because of the pull which is created by the puborectalis sling, and that is what is expected. But if I am getting a paradoxical reduction in the anorectal angle during a strain and defecation phase, that is abnormal. Because in spite of what is expected, I want the puborectalis to relax, I want what is expected is the rectum and the anal canal to come in line. If that is not happening, it is paradoxical, it is abnormal. And this is creating a dyssynergia between opening of the anal canal and the rectum not being in line with the anal canal. So this is normal. During rest, angle is somewhere close to maybe 80 degrees in this patient. During a squeeze phase, there is reduction in the anorectal angle. During strain, there is inferior descent of the pelvis and some increase in the angle. The angle has become more obtuse than what it was during rest and squeeze. And during defecation, you see that the rectum is almost in line with the anal canal, allowing good evacuation of the rectum. So what would be seen as a radiologist, for what I would be seeing is that there is delayed initiation of evacuation because the patient is not able to open the anal canal completely because the puborectalis continues to indent the posterior rectal wall. It results in impaired evacuation. The bolus of contrast which was there in the rectum is not going to flow freely across the anal canal. And paradoxical decrease in the anorectal angle when the patient is straining. We expect the angle to increase during straining and defecation, but that is not what is happening. And then there would be prominent indentation of the puborectalis sling on the posterior wall of the rectum. So this is normal. That's a normal reduction in that's the normal angle. As I mentioned, sometimes it would be 90 degrees, sometimes it would be 100 degrees, would differ from patient to patient. So during this rest in this particular patient is close to 100 degrees. What happens during squeeze? Because of the indentation pull of the puborectalis, it has got reduced. During strain, there is increase in the anorectal angle. We also see there is a cystocele with the bladder neck going down. But what happens paradoxically in dysynergetic defecation is that there is this tug on the indentation on the posterior wall of the rectum created by the puborectalis. And then instead of an expected increase in the angle, there is a paradoxical reduction in the angle. And hence the patient is not able to evacuate the rectum. Okay, so depending on at the end of a study or the end of defecation, depending on where the bolus of gel or the ultrasound gel is retained into the rectum, it could also give us some hint to what is going abnormal into the pathology. So that's the pubococcygeal line, PC line, which is drawn from the inferior margin of the pubic symphysis to the last coccygeal articulation. What has happened in this patient during the attempted defecation and straining is the anorectal junction has moved abnormally downwards. Up to 2 centimeters is expected, but it is going much more below and it is increasing, basically indicating that the pelvic floor is much lax going down. See what has happened to the anterior wall of the rectum. It has gone much anterior to the expected anterior wall of the anal canal. So patient is having an anterior rectocele, which are much more frequent than the posterior rectoceles, wherein the posterior wall of the rectum would be bulging posteriorly. That is something what we see as the rectorectal intussusception. So if this is happening, the bolus of the gel is likely to be retained above that intussusception into the proximal third of the rectum, while if I have a pelvic cul-de-sac hernia, what this cul-de-sac hernia does, it comes down and it indents the anterior wall of the distal rectum, and all the jelly, it gets retained more proximally. while in a rectocele at the end of evacuation, the jelly would be retained into the distal rectum, and we will also be able to see the presence of a rectocele during the dynamic defecation phase. Okay, so just to show you a few examples of what is happening. So this is the resting phase. We see the angle is somewhere close to 80 degrees. During squeeze, good indentation of the puborectalis, and during strain, there is much more abnormal inferior displacement of the anorectal junction. There is inferior displacement of the bladder neck as well. And this is what is happening during the defecation phase. Now the rectum is distended with jelly, but the patient is unable to defecate. Patient is unable to open the anal canal, and the rectal contents are being retained within the rectum. You would also appreciate the patient is making good effort because there is good displacement of the anterior abdominal wall when the patient is attempting to strain. Okay, so as a guideline, when the patient is unable to evacuate the rectum, he or she would be brought outside the MR gantry, would be sent to the toilet, allow them to evacuate the rectum in the vertical setting position, and then we are going to repeat the strain phase. Now see what is happening during the strain phase. Because when the rectum was full, the patient was unable to evacuate, and I could not identify a rectorectal intussusception during that particular point of time. But now if you see, after the patient has come, there is an abnormal rectorectal intussusception, and in fact there is much more abnormal inferior descent of the pelvis, and I'm also seeing probably a peritoneocele which is there sitting in between the uterus and the rectum, which I would have completely missed if I would have not repeated the strain phase after evacuation of the rectum. So this was the defecation phase with the rectum being distended. The patient is unable to evacuate the rectum, while when post-evacuation strain phase, you'll appreciate that the bladder neck is much more lower down. The uterus also has gone much more lower down, and we are actually seeing a rectorectal intussusception during this. So this guideline strongly recommends that we repeat a strain phase if the patient is unable to evacuate the rectum. So this is what we'll be commonly be encountering. That's the resting phase. That's the squeeze phase where you see reduction in the anorectal angle. Then that's the strain phase with with a expected, I won't say abnormal unless and until we see it continuing, with inferior descent of the anorectal junction. The patient is unable to evacuate the rectum, and then we repeat the strain phase and see this much more abnormal pelvic floor laxity and descent of the perineum caudally. This is what a report would mention. I have already clarified what PC line. PC line corresponds to the pubococcygeal line, which is drawn from the inferior margin of the pubic symphysis to the last coccygeal articulation. It basically gives us a reference mark for the pelvic floor. The anorectal junction could lie above this or within 2 centimeters inferior to the presence of the PC line. The H line is the hiatus line that we draw from the inferior margin of the pubic symphysis to the anorectal junction. Up to 6 centimeters is considered to be normal, and ultimately is the M line, which is basically a perpendicular which is drawn between the pubococcygeal line to the anorectal junction, and it gives us a reference to what degree the anorectal junction is moving during different phases of a dynamic defecogram study. That's about it. Nothing too complex about it. So coming to take-home message, what we've seen today is it would MR defecogram, if the patient is compliant and understood the procedure, it would allow us to evaluate good anatomic as well as physiological function of the pelvic floor and the other presence or absence of pelvic prolapse, including all the 3 compartments. It may happen that the patient has gone predominantly to a gynecologist to evaluate the uterus, but while doing an MR defecogram, we would also see that there is some abnormality in the anterior and posterior compartment as well. And patient may require therapeutic management for the same. So it will help us, it is a good guide to distinguish between surgical and non-surgical cases as cases with dysenergetic defecation. It would also may plan or modify the surgical intervention required depending on what degree of prolapse is happening in what compartment, which was initially not picked up during clinical assessment. And this is one particular study which it is completely patient dependent. If the patient is unable to comprehend what is to be done, the study is a failed study. So as a radiologist, it is my responsibility to make the patient understand what exactly is expected out of them in the MR gantry. Patient education and some minimal basic mathematics, which would probably evaporate in the future, would give us a good result in MR difficogram. And what we are actually seeing patients coming to us may be tip of the iceberg. We never know that this could actually be a big clinical component to it, and many more patients coming to us in the future. Thank you so much.
Thanks, Darshan, for demystifying such a seemingly complex topic. I think the questions are going to be taken at the end. So
Thank you so much.
I'd like to call the next speaker, Dr. Rupali Bandgar. She's a gastrophysiologist and a biofeedback specialist. Dr. Trupti, please introduce our next speaker.
Dr. Rupali Bandgar Jankar, MD in Physiology, work as an assistant professor in a medical college for 5 years. She is currently a full-time gastrophysiologist at Kaizen Gastrocare, Wakad, Pune. Dr. Rupali is one of the few physiologists in India specializing in gastrophysiology. Her core interests include GI physiology, GI motility, and biofeedback therapy. Thank you.
Thank you. Good evening, all. We have so far seen the constipation and the nice medical manage of constipation and even the MR difficogram. Now we'll go ahead and we'll see about the biofeedback. Okay, so we'll see about the biofeedback, which we are now rampantly using for the dyssynergic defecation. So the word biofeedback, this is not. See, it's not.
एक सेकंड ते येतोय.
I can show you this. I love from here.
Yeah, एक सेकंड. Already changed.
I have to just press this, right?
And back and like this.
Yeah. Excuse me, but here it's not synchronizing. Here it's not synchronizing with the slide which is coming there. Yeah.
Last slide.
As the topic is little bit unknown and complicated, so is technical thing happening here. Still it's not synchronizing. Okay, anyways, I have to look here. Will that be okay in between? Okay, so like the biofeedback, the word, the biofeedback itself is like, I'll just stand a little bit like this. So the word biofeedback, the bio in it is basically the various bodily activities or the function, and feedback is basically we give the real-time information so that we can adjust those functions. That's what is basically the simple meaning of the biofeedback. So biofeedback is basically a instrument-based learning process. Here we record the various bodily activities of the patient, like the pelvic floor contraction, and then we provide visual, auditory, or the verbal feedback. And these feedback, basically it will be helpful to give the behavioral reinforcement, and this help in the improvement of that particular bodily function. So biofeedback basically work on the principle of operant conditioning, or we can say on the trial and error basis. So biofeedback in the field of gastroenterology was first introduced actually for the fecal incontinence during 1974, and then later it was started for the dyssynergic defecation in the 1987. So the indication for the biofeedback, the first and the foremost which we have gathered here to listen is the dyssynergic defecation. I think this has time, this is going ahead even if I'm not pressing anything. Okay. So dyssynergic defecation. After that, the fecal incontinence. Here, the indication for the biofeedback for the fecal incontinence, we need to be having the intact muscle to train the patient of the fecal incontinence. And the aim of biofeedback therapy for fecal incontinence will be to improve the strength of the pelvic floor and to hyposensitize, little bit hyposensitizing the rectal wall will be the aim. Then the post-surgical rehabilitation, like after the sphincteroplasty to help in the gaining of the strength. Then low anterior rectal syndrome. This here the patient will come with urgentinence, diarrhea. So we can help them actually by retraining their rectal wall, but rectum has to be preserved there. And then also we can help them by strengthening pelvic floor. Then the levator ani syndrome. Here we can work on the pelvic floor relaxation. Then the pelvic organ prolapse. Here already if the patients are diagnosed and they have underlying dyssynergia, then we can give them a sandwich biofeedback therapy like pre-operative and the post-operative. The outcome of the patient with this will be much better. Then the pediatric pelvic floor disorders, same like dyssynergia and fecal incontinence. Sexual dysfunction like vaginismus. Then the urinary incontinence and stress urinary incontinence and urge urinary incontinence. Though I'm not much working on these last three indications, I'm mainly working with the constipation and pelvic floor related, means colon related indications I'm working more. As it is important to know the indication, it is definitely important to know in whom it is not recommended. So severe neurological disorder, as sir has said, if there are neurological disorders, the nerve muscle coordination is not perfect, then it will be difficult to go for the biofeedback. Then the severe anal sphincter damage, if there is, there has to be intact anal sphincter for the proper biofeedback or successful biofeedback. Then age less than 8 years. Here we can actually titrate. If the kid is smart enough to understand what you are talking and what you are showing them on the screen, then we can go ahead. Like one 7-year girl, even if I'm not touching. Nothing is working.
Just he use का
हे पण नाही. Okay.
okay ना का use करो. It's not working.
It's not working.
Find a problem है. Let it go.
Age less than 8 years. So this is like we need to titrate. If the kid is able to understand what we are telling them and what he's seeing on the screen, we can take the patient around that age. Because we work with a 7-year kid, she had a mild rectocele with underlying dyssynergic defecation. She really did well with biofeedback therapy. Then the uncontrolled psychiatric disorders, learning disabilities, visual impairment, dementia. If these are patients are having some of these conditions, then it will be really difficult on our part to make them understand and motivate them. So it's better to avoid the patient having these issues. Then now we'll see what is the dyssynergic defecation. It is basically a one cause of the chronic functional primary constipation. Here there is it's a acquired behavioral, it's an acquired behavioral disorder with an impaired ability to coordinate between the abdominal, anal and the pelvic floor muscle. and it like affects 40% of the patient with chronic constipation. Okay, so videographically, if we have to see what exactly how will look as a dysenergic defecation. So in case of normal defecation, the rectal is pushing and anal is relaxing and this defecation happens. But when there is dysenergia, so there will be either issue at the contraction at the anal wall, there will be the paradoxical contraction, or there will be either the ineffective or inadequate push effort. Either of these two things will be there in case of dysenergic defecation. We will first see which like patient, how they will come, with which complaints they will come. They will definitely come with the functional constipation like symptoms. So we have to see the Rome 4 criteria for the functional constipation. So here must includes 2 or more of the following symptoms. That too during defecation they should have it more than 25% of the time. Straining during the defecation, they should have lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal blockage or obstruction. Then they will be using various digital methods or manual for evacuation. Fewer than 3 bowel movement per week. These are the main symptoms where we can concentrate or we can take this patient for the further evaluation for the dysenergic defecation. So the dysenergic defecation, once like we have seen those symptoms, we need to confirm that those patients for the dysenergic defecation with the help of manometry. So Dr. Rao has really given very nice the 4 types of dysenergic defecation. So here basically in type 1 dysenergia, what happens? If you could try to visualize that diagram which we have seen in the video, the rectal pressure is adequate, but the anal down, the rectal pressure is adequate, but the anal wall is contracting is the type 1, where the rectal pressure is inadequate, but there is paradoxical anal contraction is type 2. When there is inadequate rectal pressure, the adequate rectal pressure and incomplete relaxation of the anal wall, that is a type 3. And for the type 4, inadequate rectal pressure and incomplete relaxation of the anal wall is what is type 4 dysenergia. So the devices which we can use for the biofeedback therapy will be the manometry, anorectal manometry, and the EMG based devices. So anorectal manometry is what I usually use. It gives like various the real time pressure changes into the rectum and the anal canal. And apart from that, it also gives the sensory changes in the rectum wall, which we can further use for the biofeedback therapy. And the second important device is the EMG based device. Here it mainly works through the striated muscle, like striated muscle is what the EMG work on. This is actually more rampantly used as it is like cheap and easily available. The another device which is like coming into the market by the LSR company, they are trying to incorporate EMG based devices with the that software of the manometry. So I haven't used, looking forward for that. So biofeedback therapy for the constipation, we go through a certain protocol which like again is given by Dr. Satish Rao. So here the 3 phases they have divided. The phase 1 is for the evaluation and enrollment. Here we can say this is the phase of talking. Like we need to be rightly going through the proper history taking, then deciding about the evaluation and everything. Then the second step is the active phase of the biofeedback therapy, where we focus on doing and then the reinforcement. So first phase of the biofeedback therapy, which I have shown like evaluation, here we will first go through all the symptoms, and I think the 10 commandments of constipation which sir has covered, that is what basically the starting point of this phase, evaluation and enrollment. We should know the, like this is actually for pain, but that's what we can use for symptom analysis for the dyssynergic defecation also, so that we can know our progress in the biofeedback therapy. Then maintaining the stool diary, this is the place exactly where that 10 commandment will come, like how is the stool, how is the frequency, what time he's going, how much time he's taking, everything, how is the consistency of the stool. He should maintain at the start and have to be like maintaining throughout the procedure also. So after like going these two important things, we have to take them for the test for the diagnosis. We will go for the manometry, we'll go for colonic transit study, MRI defecogram, all this study we'll do. And once like we have diagnosis, now like the correction, little bit correction while talking phase will come. The thorough history of laxative is also needed so that we can tailor and little bit go on deciding which laxative to keep, how to taper it with a biofeedback therapy. Straight away, we cannot stop the laxatives. We have to go on tapering the laxatives with the biofeedback therapy as the patient goes on progressing with the symptom improvement. Then correct sitting posture, like the sir, even in MR defecogram, we have seen little bit for this. The correct sitting posture really matters a lot because it gives the proper rectoanal angle, and a proper push effort will be put with the help of the correct sitting posture. So nowadays, like Western toilet is everywhere, at every place, even the villages have started getting the Western toilet. But the disadvantage of it is that what is it causing? The help of that rectoanal angle, which was in there for the normal defecation squatting process, is going. Why? Because in this position, the puborectalis is in contracted stage, and that's why the angle is here the acute. And what we want, how can we correct it? By using the squatty pot, which sir has also told in his previous slides. So that what will that do? Once that stool comes below your feet, automatically a little bit hip flexion will occur, and the separation, the legs will already be nicely separately placed. So the next thing which we have to work on, the correct sitting, the back, straight, proper back. For that, the person should bend his the elbow and keep it on the knee. So automatically that angle and the puborectalis will go relax, and that rectoanal angle will come obtuse, or it increases, and it gives a nice direction for passing the stool. So correct talking is really important and required in the before going to the biofeedback therapy. So after correcting the posture, we have to talk about the time toilet training. So for the time toilet training, what we can do, those who are using the mobile in the toilet, we can ask them to use the same mobile just to put alarm, keep it outside your washroom. Whenever, like 5-minute alarm for and keep it outside the washroom. Once that get hit, you come out. This is like the starting phase, so that they should not strain too much in the toilet. And another thing which Sarunke sir has focused is, whenever you get urge to pass, they should go. So, and go with the natural stimulations, like wake and go, eat and go. So like after eating 15 to 20 minutes, you usually get that colonic reflex. So better to go in that time and never postpone your motion. So these 2-3 things we have to focus in the time toilet training. Then the diaphragmatic breathing. This you can take as a homework for the patient. You can give this as a homework to the patient, so that we will understand that this particular patient is really motivated or not for going to the biofeedback therapy. Here we just teach them the simple diaphragmatic breathing or abdominal breathing, wherein the patient inhale deeply and slowly through the nose, distending the abdomen. We have to give the example of balloon. Because many times when we say breathe in and your abdomen should come out, patients will say like, how it will happen? But we have to make them realize this is what's supposed to be happen. Like after breathing in, the abdomen should distend, and breathing out has to be slow through the purse mouth. So this homework patient should be doing at home for at least a week or 2 weeks before going to the next phase of the biofeedback therapy. So this is actually the active phase of the biofeedback therapy where we will start doing the sessions. So here basically we take them or counsel them for 4 to 6 session of the biofeedback therapy. We place 1 to 2 weekly depending upon the need of the patient, and the duration of the each session will be 30 to 90 minutes. Starting phase of the therapy, it will be lengthier as we go on progressing. Then the training is usually performed upright, is basically done with the solid state, but here we usually have water perfuse system, so I do it in the lateral position. Patient preparation is like, it's better if the rectum is empty, so we can advise them using enema if it is not empty 2 hours prior to the procedure, or we can even give the laxative a day before. Like this is my unit setup where the patient is lying in the left lateral position. I have adjusted in such a way that patients should nicely see the screen, and I can also talk to them face to face, not like standing behind them and giving them whatever verbal feedback. So this is how I do. Then now what exactly we do in those sessions. So first 2 to 3 sessions I plan for targeting the individual defecation problem. In the dyssynergic defecation, we have seen there is either problem in the paradoxical, like there is either the paradoxical contraction or inadequate relaxation of the anal canal muscle, means the anal canal. Then the ineffective rectal propulsion, means we can say for time being abdominal part, and then impaired rectal sensation. So these 2-3 things, like we will be focusing individually one by one. So how we focus for the paradoxical contraction or the inadequate anal sphincter relaxation. So here basically throughout the process we have to ask the patient to see the screen and start to recognizing that your anal muscle down there can be controlled by yourself, by telling them that let the patient squeeze and observe the screen, and make them aware that this is the muscle you can control, and you just have to now control it to relax, learn to relax. So then the anal sphincter relaxation sensation we can give them. First, we ask them to contract, ask them to learn to feel that muscle can be controlled, and then we go for the relaxation. So the relaxation basically we can do that relaxation by 2 ways. One is the passive relaxation, like sir has already mentioned, recto-anal inhibitory reflex is what we can use here. But more than this, I prefer using this, active anal, more than passive relaxation, I prefer using the active anal sphincter contraction. Means first give the patient the feeling of contraction, and what follows is the relaxation. So just make patient more and more aware about the feeling of relaxation is what basically the aim of us here. And we have to continuously keep on giving them visual and the verbal biofeedback. Just see here, like this is, I'm focusing only on the anal area. So that red strip, I use both the screen. That screen also works, this screen also works. So here the patient, that red strip on the red side of you, that is the squeeze. Now the patient is squeezing, which can be seen on the biofeedback software. And then we ask the patient to relax. And the patient will start appreciating. Now, this small relaxation which you have seen, it takes really long time for certain patient. So not just patient, you also have a lot of patience when you are going for the biofeedback therapy, because appreciation of relaxation, it really take little bit more time, and that's why it's always better to cater one thing at a time. So like this is how we go for the anal relaxation. Then the Inadequate rectal propulsion. Here, if the half part will be done if we correct the posture. The correct posture also gives the right abdominal push effort which will be needed. Then what we can do, we have to train them the diaphragmatic breathing actually. First I will cover that, which we have already seen. Here it helps a lot. We have to train them a nice and proper diaphragmatic breathing where they understand like when to distend and when to like contract the abdomen. Then we have to give them indication about how to go about the pushing. So here the patient should focus on halfway inspiration. Halfway inspiration will little bit distend your abdomen, then hold the breath. After holding the breath, we have to ask the patient to push. So it's like Valsalva. If you could try to correlate, just take the halfway inspiration, hold the breath and push. This is how like we have to keep on giving them target. Like suppose in the today he is going up to 20, next time he have by practicing he should go to the 30 and 40. This way it's like trial and error, day by day progress. And one more thing we have to like advise to the patient when they go for attempting the like defecation, as they are really pissed off with not passing, what they try to do, they just push it like anything that they want everything out in that moment. So we have to train them or we have to teach them that you have to go slowly even when you are going for the pushing, because you don't have the relaxation down and you are just pushing. So that also like we have to work on. So this is how like I do in my setup for push. So like first we have to ask the patient to take a halfway inspiration, hold the breath and then try to push. At start, this patient is having inadequate push effort. So here the patient has started taking the inspiration, ask him to hold and give him target or ask him to push more and more as we go on progressing in the therapy. Okay. So this is like individualized. We are not even, not yet started coordinating. We are individualizing. First focusing on the anal area, then focusing on the rectal area. So then they will understand it much better. And at the end, then next 2 to 3 session, I focus on the recto-anal coordination, which become easy for the patient to understand. So in the recto-anal coordination, whatever they have learned in first 2 to 3 session, they just have to correlate it. Like the anal relaxation, they have nicely understood the feeling of anal relaxation and they now even know how to modify their push. So basically what we have to now here give them, when they are halfway taking breathing, halfway inspiration and hold period is there, right? We are asking them to little bit like that hold. So start of hold, we can ask the patient, try to take the feeling of that anal relaxation and then push. So this way, like halfway inspiration, hold the breath is equivalent to anal relaxation and give push. So this way we try to like titrate in each session, but I usually go in the last 2 to 3 session. First I focus on individual need. This is how we go. Okay, so now the patient has started pushing and same time we are asking him to be conscious about the anal relaxation also. Though it is looking very easy, but it's really hard for those dysenergic defecation patient to feel that relaxation and try to coordinate that with the push. So like it's our duty to give them confidence every time and motivate them that it is happening, it will happen. You just go on practicing. This biofeedback therapy basically takes multiple visits. It takes long duration. So it is really important that we have to continuously keep on counseling them in between sessions also. So apart from this, so these sessions, like now, first 2 to 3 sessions, last 2 to 3 sessions. So now when we can stop the giving these sessions? Sorry. So if there is a consistent coordinated pattern of defecation with good anal relaxation is there, or there is improved stooling habit and normal balloon expulsion. So this is the time when we can think for stopping of the session. But I think the third part has gone. Okay. The third and the last part, which is there, that is the reinforcement. Sorry. It's still coming. So when to stop, like we have seen, if the proper consistent pattern of rectoanal coordination we have got, and there is balloon expulsion, then this second phase of biofeedback therapy we can stop. But during this second phase of biofeedback therapy, I also focus on giving them the pelvic floor relaxation exercises, some of the core strengthening exercises, the diet counseling, and the very important psychiatric counseling. Some of the patient with dyssynergic defecation, not some, there might be actually more number. Research is not going on about the gut-brain axis more and more. So we have to take the help of psychiatric counseling if it is really needed, but not in the start of the therapy. As we go on and when the patients start becoming comfortable, we can advise them for the psychiatric counseling. This will definitely help us to improve the outcome of the biofeedback therapy. And then the last phase, that is the reinforcement phase. After the patient is nicely done the balloon expulsion, then we go for the reinforcement. This reinforcement we do 6 weeks after the completion of therapy, then 3 months, then 6 months and 12 months. This is just to make sure that the patient is doing it and he is consistent with the rectoanal coordination pattern. He should not come back again with the same dyssynergia. Just like we have to ask the patient, you need to be continue doing this at home. So home devices, if it really become available easily, it will be helpful like anything. The one more topic which I would like to cover is the dyssynergic defecation and hemorrhoids. Like in our OPD, many times the hemorrhoid patient, they come, and when we start taking the history, then they will almost start presenting with the constipation and dyssynergic defecation complaints. So even the research has shown that 30 to 50% of these patients with chronic hemorrhoids, they exhibit signs of dyssynergic defecation. That too, in 42% of the cases, even there is diagnosed dyssynergic defecation. And if there is improvement in the dyssynergic defecation, it even reduces the hemorrhoid symptoms in 65% of the patient after the biofeedback therapy. So like as many of you are like surgical people, you will be feeling like this, chicken and egg concept, whether the dyssynergic defecation or the hemorrhoids. So whatever, as it has bidirectional relationship, but what you can do along with the medical and the surgical management, if giving importance to the underlying root cause, that is the dyssynergic defecation, which can be catered with the biofeedback therapy, will definitely help for the proper or the good outcome of the hemorrhoids, and also help for the good quality of life. So like as we all are clinician, we want evidence-based practices. So there are certain evidences for the biofeedback therapy. So the randomized control trial in refractory constipation patient with pelvic floor disorder, it has shown that 80% of the success rate up to 1 year. Then symptomatic improvement in ODS patient, again the after some years they have again conducted the study, it also shown the 80% of the symptom improvement. Then biofeedback is superior to the diet, laxative or sham feedback in the dyssynergic defecation. Various randomized studies have been shown this result. Now like still like how much authentic these particular evidences are, that study was also done to get that The dysynergic defecation, the short-term and the long-term treatment in the dysynergic defecation, we have got level 1 or the grade 1 evidence. For the fecal incontinence, again in the short-term and the long-term treatment, there was level 2 and the grade B strength of evidence was found. Then for treatment for the levator ani and dyssynergia, the level 2 and the grade B evidence was found. And for the treatment of solitary rectal ulcer and dyssynergia, the grade 3, level 3 and the grade C evidences was found. This study was also done by Dr. Satish Rao sir. So I'll just like to take you through one case study or the case story. Here, a 45-year lady, she was like diagnosed case of solitary rectal ulcer syndrome. We had come our clinic with a chronic constipation along with SRUS. So we did evaluation for that patient. We did colonoscopy to reconfirm the SRUS as that was really long standing. Then we did defecogram to get to know that that was showing mild rectocele, and the anal manometry. On the anal manometry, we got the type 1 dyssynergia. So along with the medical management for the SRUS, we have we have put this patient on the biofeedback therapy. These are her starting parameters. If you could see, I'm just popping out the push and the relaxation pressures. Here the push is 58. If you could compare with the normal, it is okay. So we can consider this as adequate push efforts. If you see the relaxation, it is in the minus, means there is paradoxical contraction happening. So this is a type 1 dyssynergia. So we have started putting this patient on biofeedback therapy, and after the 4 session of biofeedback therapy, there was improvement in her push pressure. Push pressure was already adequate, so that was adequate. But the improvement in the push relaxation was significant, and she even expelled the balloon within the 11 seconds. Previously, she has took almost 120 seconds, if you could see in the down part. She has took the 120 seconds for passing the balloon. But after the therapy, she passed it after 11 seconds. Even like the down images, that the last third image is of proper push, where the upside, the dark color are more pressure and the light colors are the less pressure. So upper part is the push, lower part is the relaxation. So this is post biofeedback therapy, post 4 sessions of biofeedback therapy. So the conclusion is biofeedback therapy, we can say it's a proven therapy for pelvic floor disorder, and it is safe and supported by various evidences. Then biofeedback therapy, we have to individualize this. We cannot fix that this is 1, 2, 3, 4 for you. No, it is not. It is like 4 for someone, it is 5 for someone, it is 1 for someone. So we have to tailor depending upon the individual need of the patient, and importance of patient selection, like it is really require a well motivated patient to go through the biofeedback therapy. Thank you.
Thank you, Dr. Rupali, for an excellent lecture on biofeedback. We'll take question answer in the end. Okay. I'll like to invite our next speaker, Dr. Dipti, and she's a physiotherapist. And as you all know, that any problem with the muscle has to be set right with a series of exercises to strengthen the muscle. So she will enlighten us about it. I request Ms. Tripti to introduce her.
Dr. Dipti Gudduru is an experienced physiotherapist specializing in women's health, geriatric, and trauma and orthopedics. With 22 years of experience, including 17 years as a specialist. She completed her BPTH from Sri Ramachandra College of Physiotherapists in 2003 and an international master's course from MGHIHP in 2005. She is a member of the Indian Association of Physiotherapists. Ma'am, please.
Thank you so much for that introduction. I want to thank Kaizen Gastro Care and the Society of Colorectal Surgeons. Thank you so much for adding a physiotherapist to your CME. because it's always tough following such good eminent speakers, because most of it today is about functional gastro, and we form like a small cog in the wheel in functional gastroenterological disorders. It depends on your interest. I mean, when you think about physiotherapy and how is it connected to gastroenterology, but like somebody who is eminent sir was telling, it's if it's a muscle and bone, you please think of us. So most of my slides, I realize, are going to be redundant because Sanjay sir has done such a great job, and Dr. Rupali and the radiologist also. So our work kind of overlaps. So I'll try to skip a few slides just to not to bore you guys before dinner. So how we view the pelvic floor is as a sling muscle. And the reason this muscle is very different for a physiotherapist is, oh, sorry.
Play.
So how we view this muscle is as a sling muscle because it's one of the only two horizontal muscles in the body. So I didn't add it in here because I thought it was going to be boring, but it's very important to know that the pelvic floor is made of the same two type of fibers, which is type 1 and type 2. The difference being the majority of the fibers, somewhere close to 50 to 70% are type 1, which are fibers which are for endurance or holding capacity. That's why they're able to hold the weight of the 3 pelvic organs. And type 2 fibers are the sphincteric fibers. So the type 2 fibers are the ones which control the urethral sphincter or the rectal sphincter. They form anywhere between 5 to 20% depending on the person. So we therapists love our anatomy, and as sir was telling, we do focus on the innervations and the muscles also. I'm not going to give you an anatomy lesson today, but just to give you a view of our perception when we assess a patient. We are looking not just at the levator ani, we are looking at all the pelvic muscles and the ancillary muscles around it. That the levator ani is the puborectalis, pubococcygeus, iliococcygeus. The coccygeus is not a levator ani, but we do consider it a lot in pelvic floor rehab. And going into the layers, I've used a female model just because it's more descriptive. So when we do a PR or a PV, our palpation of muscles is very different. We use a clock. It's called an A clock. So we go according to quadrants, 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock. So when we are assessing muscle strength, we actually look at individual muscle strength. We look at symmetry, whether one side is stronger, one side is weaker. We are looking at the pressure. I'll show a slide which shows how the difference is, but we are also looking at the soft tissue. So sometimes what we think is a muscle might not be a muscle. It could be a perineal descent. So we are looking at the bony landmarks also. So bony landmarks for us are very important because we do a lot of musculoskeletal work. So we base our treatment on the bony landmarks. And this is the deeper layer of the pelvic floor. Here you can see if we have to do a PR, so that would where it would be, which gives us a really clear access to the puborectalis and the external sphincter. Also to be noted is we can access the piriformis and the obturator muscle on the sides. Why these are significant, we'll come to it. When we are talking about posture or breathing or defecation, everything is controlled by those muscles. So when you think pelvic floor, please just don't think about the levator ani or the sphincters. Please think about all the muscles in and around the rectal and the vaginal canals. This Dr. Rupali did go over as what to the pelvic floor does: bladder and bowel control, pelvic organ support, the sphincteric function, sexual function, breathing, pregnancy, and childbirth. Like I said, this is how we visualize the pelvic floor with the sling muscles around it. But also, very importantly, pelvic floor is a stabilizing muscle. For us, I mean, as a gastroenterologist, it's an evacuating muscle, but it forms the stabilizing part of our core. So abdomen, lateral abdominal wall, back muscles, and the pelvic floor together form one system. So it's never actually activated or working individually. It always works in synergy with the rest of these muscles. I'm going to skip this one. So as a therapist, when does a gastroenterologist or a colorectal surgeon think about us? In my practice, we also do a lot of urogynec and urinary work, but this being a CME with gastros and colorectal surgeons, the common referrals we get are functional fecal incontinence, alorectal pain, proctalgias, levator ani syndrome, unspecified anorectal pains. Functional defecatory disorders is our bread and butter because those are the most prescribed. So that's dysynergic defecation and inadequate defecatory propulsion or slow motility constipation. So how do I look at this, classifying it even more? Is types of functional constipation, like we said, dysynergic defecation, slow transit, colonic. So we send out these flyers to consultants in case they don't realize, okay, at what point do we give it to a therapist before we either go into surgery or we are going into, further laxative use. So how else do we see it? Anismus, pelvic floor dyssynergia, obstructed defecation, paradoxical puborectalis contraction, non-relaxing puborectalis, pelvic outlet obstruction, and spastic pelvic floor. I'm not going to dwell into what are the neurological causes or if it's an upper motor, lower motor, but when you hear these diagnoses, please think that if there is a pelvic floor involvement, there is a role for a pelvic floor therapist here. And I'm skipping to the bladder functions, but I think I can skip the whole thing. So Dr. Rupali covered this, so I'm going to quickly go through it. But when you see a paradoxical external anal sphincter or puborectalis contraction, involuntary anal spasm or inadequate anal relaxation, inadequate puborectalis or impaired abdominal or rectal pushing, this is when you think about a physical therapist or that this person needs a correction. This can be either seen by a simple rectal examination, or you could do this in an anal manometry, or a diagnostic biofeedback can also give you the same results. So what are the common symptoms when you see this? Is excessive straining, abdominal bloating, passage of stools being hard, less bowel movements per week, digital maneuvers as disimpaction, that is digital evacuation, vaginal splinting, feeling of incomplete evacuation, which is the most common complaint we see. And what are the associated symptoms? So it's never a single symptom of constipation. I think it's the other way around. Usually abroad when we practice, they come to the physical therapy first. So we try to do as much and then we refer. But by the time they come to us, everything is like a mixed bag of masala for us. So they also have urinary symptoms, they have sexual symptoms, they have low back aches, and a lot of pelvic pain, which does not have a simple diagnosis. So again, this being a gastro conference, I'm not going to coach you on what other symptoms there are, but when you're looking at muscles, we also look at something called perineal descent. This might or might not be picked up in the defecography, like Sir had mentioned, because it depends on the squatting position. If you were able to squat better, the perineal descent is more apparent. But if you're not squatting, you do not actually pick it up in a radiograph. But when you ask the patient, when a physical therapist is examining a patient and we ask them to create intrarectal pressure versus intra-abdominal pressure, you can see the perineal muscles actually try to come outwards. We are not only looking at the sphincter, but we are looking at the connections of all of them from the ischial tuberosities to the perineum. We see this definitely more in obstetric traumas or, women who are postmenopausal, but chronic constipation also causes ballooning of the perineum. So the patient, how this is significant is we are constantly teaching the patient how to evacuate through the sphincter. But the patient cannot create pressure in the sphincter because the abdominal pressure is being dissipated throughout the pelvic floor. He's pushing the whole pelvic floor down, female or male. So to isolate it in the rectum becomes very hard for the patient. I'm going to skip this one because it was covered before. So this is a chart I use for anal incontinence, but the same goes for dysynergic defecation and disorders also. When do you refer them to the therapist? So the primary physician or the gastroenterologist, whoever is seeing them, if they feel this is more of a musculoskeletal, with your history taking, you realize it's more of a musculoskeletal disorder, please do give it a try, referring it to physiotherapy. And what do we do in physiotherapy? I shall cover it in detail. And there is always a cross-referral system. Like I said, we are a small cog in the wheel. we cannot rule out a lot of, differential diagnosis. So most of the times when the patients are sent to us, the differential diagnosis is already done because we do not deal with organic causes of constipation. But once all these scans are done, and then you still realize, okay, we can't actually put our finger on this, and this is more of a neuromuscular problem, then the referral comes back to us and back and forth. And how does a physical therapy examination work? I actually trained as a musculoskeletal therapist. So we are very thorough in how we take history and how we check, but we also do a Bristol stool scale. We do a bowel diary. We do a very thorough pelvic floor assessment, abdominal assessment, and our squeeze pressure. So because we do not use diagnostic biofeedback, if I have a manometry in front of me or a defecography, I'm a lucky girl. But if I don't have them, it is very subjective because if I check and the other therapist checks, definitely there's a difference, but we have our own grading system. I'll go through it. It's called a perfecta score as to how I assess. But for example, when I'm saying the patient's push pressure, but I also always note that the push is an intra-abdominal push versus an intra-rectal push. Or if I'm talking about squeeze, I will say, is it a squeeze of the sphincter, or is the patient using his adductors to squeeze? So the patient is actually not squeezing properly, he's using his ancillary muscles. And just like Dr. Ripali was saying, our resting tone, maximum contraction, hold time, and how many repetitions the patient is doing. Initially, we would just do a modified Oxford scale, which is 1, 2, 3, 4, 5 for any muscle. We do that for any skeletal muscle. But for pelvic floor, it is different. When we do it in different settings also in rest, we look at it, we ask the patient to cough or sneeze, and we ask the patient to bear down. So the testing is done in various positions. So we check for the power of the muscle, the endurance, the number of times each contraction is repeated, how fast or slow they can do it, if there is a perineal elevation. So the levator, we call it a levator lift. So can they actually not just squeeze, but also elevate the whole pelvic floor? Are there any co-contractions of the muscles around it? And what is the time they can finish 20 repetitions? And can they voluntarily relax after the contraction? So what are the goals of pelvic floor training in defecatory disorders? To optimize the stool consistency, to normalize the urge, normalize frequency and defecation, and what exactly is pelvic floor muscle training? I will simplify it because it's, like I said, quite boring if we get into the details. We are optimizing the exit. We are optimizing the exit of the stool, and we are working on the pelvic floor muscle, the puborectalis, and the external anal sphincter individually. We work on the proprioception and normalize the rectal sensation and management of rectal compliance and capacity. So we were talking in the beginning about type 1 and type 2 fibers. So putting biofeedback aside, which is a great tool, sometimes what happens is innervation is not intact or the muscle has lost its elasticity. So when we are dealing with muscles which are not as compliant as a regular skeletal muscle, you do not get the same feedback as a stronger muscle. So we look at type 1 separately and type 2. So rehabilitation for type 1 is more of a slow contract and more of a hold, whereas for a type 2 fiber, where the patient is not able to generate pressure, it is more fast contractions. The number of contractions and rest periods are smaller. Some of the referrals we get from the surgeons are rectal prolapse, mucosal interceptions, solitary rectal ulcers, rectocele, enteroceles, and descending perineum syndromes. So I'm not great with classification here, but usually anything they've said that probably is not going to be operated and they want to do a conservative management ends up at our table. But once in a while, before going for surgery, they ask for a prehabilitation. So they realize the muscles are weak to start with. So the outcome of the surgery is definitely better. You strengthen the pelvic floor muscles and then go in for surgery. Definitely the chances of recurrence is much lesser. And how do we start our physical therapy management? Lots and lots and lots of patient education. First, making the patient understand the baseline. because there's never a normal baseline for anybody. So if this patient has dyssynergic defecation type 1, 2, 3, 4, or any kind of pain, the baseline has to be understood and the goals have to be set initially, because patient compliance is everything in rehabilitation. And our referral doctors are so great because they are picking the right patient. If the patient is resisting to therapy, it is not easy because it takes us a long time to bring in compliance. We start with defecatory mechanics. This was gone through before also. The difference I would like to tell how physical therapy helps this. Let us say the patient has tight hip flexors, or he has back pain, or the patient is training and he's not able to get enough air. This is where physiotherapy comes to help. We release the diaphragm. We actually work on diaphragmatic muscles. So the patient is not able to take a deep breath. We will release the abdomen. We will check for the expiratory capacity. It just takes one session. Or the patient will say, I'm sitting and my tailbone hurts. So a small manipulation of the tailbone, so that because probably the puborectalis was pulling too hard on the coccyx, and the patient automatically associates pain with defecation and there is more dyssynergia. So we also teach pushing strategies, manual perineal support if needed for a lot of gynec patients, and abdominal massage and pelvic floor muscle individual rehabilitation. So this is the example of something we call I love you massage. It's the ILU massage. So it's a specific technique. I mean, I think my grandma probably did a better job of it, but so we teach the patient, we first put a hot compress for about 15-20 minutes, and we start teaching them circular massage techniques with their own hands. So we make them do this once at night, once post meal, and once when they feel the urge. We ask them to kind of calm down. And here I'm talking about dyssynergic defecation. This is obviously not for people who have diarrhea or incontinence, but this is so the first I don't know if I have a pointer, but that's the I and the L and the U. And we do it around 20 times. So you could use, my grandma told me to use sesame oil, but any oil which is non-irritant to the patient, and you vomit a little bit after a hot compress, that definitely helps a lot. We also went through the pelvic floor strengthening and relaxation exercises. The difference between strengthening and relaxation. So when we say Kegels, people just assume that the pelvic floor always has to be strengthened. But if you're having a very tight pelvic floor, relaxation comes first. So relaxation of the sphincter is hard. We will talk about it. But the relaxation of the muscles around the pelvis is quite easy. So you open up the abdominal muscles, open up the side, oblique muscles, open up the back, open up your diaphragm. The pelvic floor automatically relaxes, because there is a synergy in the movement of the pelvic floor with the diaphragm. As the diaphragm goes up, the pelvic floor goes up. The diaphragm comes down, pelvic floor comes down. If there is enough synergy, so automatically in a minute, there are 12 pelvic floor contractions as it is. So strengthening is not as important as relaxation of the pelvic floor. We also do something called Jacobson's relaxation. We've gone through the breathing exercise, so I'll focus on the Jacobson's relaxation. It's a technique which is taught to us very early on. We use it for a lot of muscle spasms. So we go through muscles from the top of your head to the tip of your toe. We are teaching people to contract and relax. Contract, relax. We put them in a very quiet room. We turn all the lights off and we try to put some calming music, and we get the person to focus on every single muscle contraction and relaxation. Because these are the people who are unable to relax their pelvic floor. The muscle is already tight, so they cannot isolate it. But as a co-contraction around it is happening, the patient slowly understands that the pelvic floor can be also relaxed. So when done every day, it's a very simple thing. You can go to YouTube, Google Jacobson's or progressive muscle relaxation. It works like a charm. Like, it also brings down anxiety. The patient's pain comes down. Also, patient slowly realizes that he was clenching his pelvic floor while defecating, and now he knows the difference between the clench and the relax. And breathing exercise, diaphragmatic breathing, abdominal breathing, two very different things. A lot of people think that abdominal pressure or abdominal push is very important. It's the actual opposite. The patient first needs to understand the thoracic breathing or diaphragmatic breathing. The pressure builds up in the thorax, abdomen will expand automatically. And defecatory mechanisms, again, I'm not going to stress on, but when we are working with certain muscles and we realize that there is more of a perineal pressure and not rectal pressure, we will try to work on the ancillary muscles to make them tighter and only focus on the rectum. How successful? I have evidence, I didn't add on it, but I'll be happy to share it. So overall success is 70 to 80% for functional defecatory disorders. That's by Dr. Rao also. And healthy function of the pelvic floor muscles will result in a stronger urge to defecate. This is where a lot of people don't think that, you know, when you're only thinking of dyssynergia, but on overall healthy pelvic floor for a woman, let's say post-menopause, you know, we refer to the gynac to say that does she have atrophic vaginitis. So first we address the pelvic floor health overall before we start treatment. And up training and down training. So these two words are important for the other therapists in the meeting, is because not every pelvic floor needs to be strengthened. It also has to be relaxed, and not every tight pelvic floor is strong. Sometimes when we release the pelvic floor, you realize it is actually very weak now, and then the strengthening starts. And very important, transverse abdominis. This is one of the most important muscles in defecation. So a lot of trigger points tend to be in it, lot of dysfunctional. Sometimes you don't even activate the muscle when you're trying to defecate. You're using all kinds of wrong muscles, and no wonder there is so much pain. So we try to strengthen the transverse abdominis and proper body mechanics. So this is a topic for another day, but I'll touch on it briefly. We use a lot of transcutaneous electrical nerve stimulation. Like I said, if it is a non-functional pelvic floor, that means there is zero. The strength on the pelvic floor is zero or like a +1. It is not even a flicker of a contraction. We start electrical stimulation. So the type 1 fibers are different. So we will use a different electrical stimulation. Type 2 fibers, different electrical stimulation. And sometimes we use, if it is an urge, we are using at an S1, S2. So we use probes at the S1, S2 or the posterior tibial, which is on the bottom of the malleoli. And if the patient is dyssynergic, they've figured everything out, but they're still struggling because it's a learned habit to keep straining. The pelvic floor is relaxed, but the patient is still trying to push. We will try electrical stimulation at the abdomen also. Other things we do for constipation or any pelvic floor disorders are scar mobilization and myofascial work. So a cesarean scar, which probably caused the patient not to have enough push pressure, can be mobilized. An episiotomy scar or an old, any kind of trauma scars, any adherence scars, deep lacerations, myofascial pains. Ultrasound is something we use in a regular practice that can be used on, rectal pains also. Good posture is everything. Mechanically, the patient is more efficient when all your muscles are working in its optimum position. And we also do a lot of balance work because proprioception is a part of your physiology which kind of triggers every other physiological reaction. So, and joint mobilization. So coccyx, sacroiliac joint, and good lumbar movements. So I'm going to skip biofeedback because we've gone through biofeedback. The difference. So when we do the difference between the pressure feedback, which Dr. Rupali does, and the feedback we do, is we don't have as many normative values because ours is an electrical biofeedback. All we are picking up is electrical potential. We don't have the same numbers for the squeeze pressures, but we see the electrical potential of each muscle. So my probe has two receptors, and one we can put it at this external sphincter, one at the internal, or you can manipulate it to put it whichever way, whichever muscle I think needs to, be rehabilitated. But what I'm looking at is the maximum contraction, is the duration of the contraction, and the relaxation. Can the patient relax voluntarily, or is the patient taking a very long time to relax? These are the same parameters which we use to rehabilitate the patient also. When we are doing 5 or 6 sessions, so the first session to the second session, I need to see a change in these parameters. And how does a changed parameter look? So when you can see group one, the difference to give you is the maximum contraction. So the squeeze pressure or the pressure of the pelvic floor, they're not able to create. It could also be that the number of fibers are not being used. It could be less number of fibers, so the strength is not good enough. In the second one, there's a lot of noise in the bottom. So that means it's not relaxing. So the patient has contracted, but the relaxation is not good enough. It is not going to baseline again. So once after treatment, group 1, you can see this was up training. So the patient, we are trying to make the pelvic floor stronger. So the contraction has become higher. In group 2, we were working on relaxation. So that means the patient can contract on will and relax on will. There is no ancillary movement. There is no extra movement of the pelvic floor. So this was also covered by in the biofeedback therapy, how this is how we base our treatment sessions on, how many times, but it's very fluid because all these patients don't usually come with one symptom. There's a lot of cognitive behavioral therapy we do also because these are learned habits. Defecation, by the time they come to us, it's a learned habit and there's a lot of anxiety. When we try to change their habits, the muscle will listen to me, but the patient will not. So when I'm working with the consultant also, and I ask them, so laxative at this point is comforting, even if it doesn't work. You're working with a stool 4 or 5, but the patient still wants to strain. So they want to sit in the bathroom for 30 minutes. There's a cleanliness obsession. So all of this, when we encounter at some point, we will refer it to a psychologist. And in conclusion, so biofeedback therapy, pelvic floor muscle rehabilitation put together actually work really well for constipation and defecatory disorders. And there's a lot of evidence which shows that just biofeedback versus biofeedback plus rehab plus a lot of CBT together brings out a lot more efficacy. And that's my friend Susie, who's trying to do her pelvic floor rehab by opening a wine bottle. And thank you. I'll take any questions after.
Thanks, Dr. Dipti, for a wonderful lecture. I'd like to invite our last eminent speaker from Mumbai today, Dr. Roy Patankar. He'll be speaking about surgical options for obstructed defecation syndrome.
Dr. Roy Patankar is a gastrointestinal, laparoscopic and colorectal surgeon in Chembur, Mumbai. With reach of experience in this field, he is the director of Zain Multispeciality Hospital, Mumbai. Dr. Patankar is well known of his fabulous work in hiatal surgery and pelvic floor surgery and is considered an authority in pelvic floor surgical procedures. Sir.
Thank you, Samrat and Team Kaizen for getting me here on relatively what is a Cinderella topic. We have enough CMEs on cancer rectum and prolapse, but there is no industry backing and relatively less interest in pelvic floor disorders. Could I have my slides? So my talk is really going to encompass, there'll be some overlaps with my previous speakers, and believe me, I've learned a lot in the last 2 hours that I'm listening to this. Slide connect karna Maja? So this is in fact my main competition. This quaternary care ISO certified Bagair operation guarantee ilaj is what kills my practice. My first disclosure is my talk is based on the last 15 years of working on pelvic floor, the many mistakes I have made and some of the lessons that I have learned from doing this. I first began the pelvic floor work in 2009, mostly by accident. My cousin's daughter had a divorce. And when she is from Pandharpur, I'm basically from Pandharpur. And going into this detail, she had SRUS and she had vaginismus. So she couldn't have intercourse with her husband and she was labeled a psychiatric girl. And she had a divorce within a month, she separated from her husband. And at that time, not many people in Mumbai were doing manometries, biofeedback, and there was no pelvic floor center. So in 2009, the city of Mumbai had 89 cardiac cath labs, but no biofeedback center because there's no money in biofeedback and it's not very fashionable, as Sanjay will probably agree with me. So I went off to learn from these people, Roland Scherer in Berlin, Dr. Longo, and many others, and I realized that there are more questions than answers in obstructive defecation. So the first step, particularly for the youngsters at the back, is you need to know that you don't know about this. Like if you'd asked me in 2009, I had no concept of anismus, of vaginismus, of obstructive defecation, and I began to train myself. If you read the chapter on constipation in the textbook of surgery by one of my favorite authors, Moshe Shine, it begins the epilogue by saying the only time human beings wish they could defecate and fart was they're not able to do so. So let's look at what is ODS. For the uninitiated, these are the nice guidelines of 2010. This is separate from constipation. To put it simplistically, a patient with constipation doesn't feel like passing stool. A patient with ODS wants to pass stool but is unable to pass stool, and the symptoms include unsuccessful evacuation attempts, considerable straining, pain, and a sensation of incomplete evacuation. There is a lot of overlap with constipation predominant IBS, as Sanjay has told you, and many patients may have both, a slow transit constipation and a pelvic floor problem. There may be some supratentorial component, and as my previous speaker said, almost a third of my patients need some form of counseling or the other. But the key issue in all of this is a weakness of the pelvic floor. So we look at this paper by Pescatori's group. It's like a locked spectrum of disorders. It's not only SRUS. There are many things that can be labeled as pelvic floor problems. And the first article that we wrote was in 2013, looking at the concept of ODS when not much was done. I know most of you here are general surgeons with interest in anorectal problems, but these, like surgeons come in all shapes and sizes, these problems comes in all shapes and sizes. And these patients commonly present to your clinic as fissures, as piles, as fistulas. And the reason for all of this is persistent straining, constipation, putting a finger in the rectum, pushing on the vagina, so-called failures of treatment. Why do patients get recurrences after piles? Dr. Rupali said piles do benefit with treatment, of course. On the other hand, when a patient with piles comes to you after the recurrence, don't blame the neighbor. He must be as good a surgeon as you are, perhaps sometimes even better. More likely there is more to it than meets the eye. Obviously rule out colorectal neoplasia, but very likely there is a pelvic floor problem. The second condition that I'm very interested in is full thickness rectal prolapse, and we have one of the largest series of prolapse surgeries in India. The problem with our surgeons is we learn one operation, and we will do that same operation for every patient of prolapse that comes to you. I bet you 80% of this audience will do posterior mesh rectopexies for rectal prolapse. And there is enough scientific data that that's an obsolete operation. There is no reason to stick a mesh behind the rectum. Suturing the rectum is as good. We now have data showing that the ventral rectopexy may be far better than a posterior rectopexy because posterior rectopexies cause de novo constipation in 20% of your patients. So these patients can come to you with just submucous prolapse. There is partial prolapse. They come to you with full thickness rectal prolapse. One of my students is currently doing a thesis on rectal prolapse. And when we do MR defecographies in these patients, almost 25-27% of full thickness rectal prolapse have associated anterior and middle compartment problems. And I bet you nobody in our country does MR defecographies for rectal prolapse. What happens? You stick a mesh or suture the rectum to the presacral fascia, the anterior middle compartments start descending, and the patient lands up with dyspareunia, SUI, overflow incontinence, and we get referred many of these patients after surgery. So this is the protocol that we follow. The first thing I want to emphasize, which the youngsters must, when you're examining a female patient with pelvic floor problems, do not only see in left lateral position. The problem is we think in silos. The general surgeon, colorectal surgeons looks at the rectum, the gynecologist does a PV, and the urologist sees them in lithotomy and looks at the anterior compartment. If you are going to evaluate all the three compartments, this patient must be seen in left lateral, lithotomy, and in squatting position. More than 90% of times, I will make and write my diagnosis on paper after examining the patients in all three positions and then send the patient for MR defecography. When you see a patient in left lateral position, one hand should be in the abdomen, seeing how he or she is contracting the abdomen. The educated finger actually gives you a lot of information that even an MR defecography may not be able to give you. But more on this later. There is simply no role of doing barium enemas because that's a structural test, not a functional test. Stop doing this. Whenever you see the pelvic floor, remember there are three compartments: the anterior compartment, the bladder, the middle compartment, the vagina and uterus, and the posterior compartment. The problem is, as surgeons, we only look at the posterior compartment. We're like an ostrich with the head in the sand, because all our knowledge and our training is only about the posterior compartment. Very rarely will we actually see patients along with our. The first thing is, look at this, patients with SRUSs. So these are some of the patients that you will see, and SRUS, they can come with you with blood and mucus in the stool. They come with this kind of proliferative growth. So the term solitary rectal ulcer is a misnomer. They are often not solitary. You may have multiple ulcers. Rather than ulcers, you may have this kind of proliferative growths, and this look like malignancy. I will do a 4-quadrant biopsy in this. I'll do narrowband imaging. I'll do MR to confirm that it's not malignant. Then go into the history. If the patient tells me he's got 5 years history of blood and mucus in stools, he's got constipation, he's putting a finger in the rectum, before the biopsy report comes, I know it's going to turn out to be SRUS, and my treatment is geared towards that. I'll keep this brief because you've seen some very elegant MRs from my colleague. Just to make the youngsters understand, there is also a concept called the enterocele, where small bowel is descending into the pouch of Douglas, and this is particularly important when you want to do a star operation, because it's a blind operation and you may accidentally take the small bowel in this. The interceptions, you've seen the MRs shown elegantly by Darshan, but this is what I call the arrowhead appearance. The post-evacuation is little different from what Darshan feels. To me, these lines are all rubbish. They're what I call TTP signs, total time pass. It just gives some absurd information to the radiologist, throw in your face to kind of justify the high amount of money they charge for MR. But what is important to me, sorry Darshan, is to see the size. Again, the size of the rectocele is completely immaterial. You may have a 6-centimeter rectocele which completely evacuates after evacuation, and I would never operate on such a patient. Remember, any multiparous patient, 20% of normal healthy pelvic floor will show rectoceles. So rectocele is not an indication of surgery. Look at the clinico-radiological, and I've done all these mistakes. I've operated on unnecessary patients. I've had patients who have bugged me afterwards. But this, I'll keep this short, I think. We're short of time. But these are some of the things. On table, you can do what is called a Parkes maneuver. So when you're doing a hemorrhoids the next time, just put in a sponge holder and try and do this. If you're seeing the descent of the rectal mucosa, go back and explore the patient's history a little bit more carefully, and perhaps you may see this. You will see things like anterior rectoceles. You see this arrowhead appearances. We have now done more than 1,000 MR defecographies. We have made mistakes. We have learned from them. We have done surgeries, had bad results, and gone back and done the MR defecographies in the same patients. One of our early data was published in the Indian Journal of Radiology, but some of the learnings we have had is, number one, the size of the rectocele is immaterial. The lines are immaterial. In a patient of full thickness rectal prolapse, what we are now doing is using AI to do the size of the levator hiatus. And that to me is a very important role to decide what kind of surgery to do. If your hiatal distance is very large, I know the perineal surgery is probably going to have a higher recurrence rate. Another learning, most of our failures have been in patients who have tricompartmental prolapses and pelvic floor descents. So do not do perineal operations if you have a pelvic floor descent. Put a mesh from ahead. So is there an ideal technique? I think Samrat specifically said, tell us when not to operate. And I can only tell you from my mistakes because a lot of literature is divided on this. Manometry is absolute marker. We have to do colonic transit. If you look at the AGA recommendation, they say manometry first. Now, over the last 5 years, I am convinced that our patients should first have a MR defecography, which at least in my hospitals costs cheaper than our own manometry. If the patient has no anatomical abnormality, then I send him or her for a manometry. I have a rider to this. Almost all MR defecographies are done by technicians, with the radiologist safely ensconced in an air-conditioned office, watching CNBC and having coffee. Sorry, Darshan, again. The important bit for me is if the patient does not strain well, he mentioned very good criteria, and we actually follow this. If the patient is not strained well, the pathologies are in the last 15-20% time of defecation. So when a patient comes to me with a normal MR defecography report and my PR findings don't correlate, I will insist on repeating MR, and more than 50% of times we will pick up an anatomical abnormality. And suddenly our protocol will change. Because the minute there is no anatomical abnormality, it's a pelvic floor dyssynergia. The only treatment is biofeedback. Send them to the Salunkes of the world or Rupalis of the world. Always. Now again, I have a slight difference from what our colleague from Hyderabad said. I will never operate on a pelvic floor patient unless he or she has done 3 sessions of biofeedback. Every single patient. Not only that, when I do ultra low AR, we do a lot of intersphincteric dissections, coloanal anastomosis, very low stapled anastomosis. Almost 50% patients get the LAR syndrome, which Dr. Rupali mentioned. And that's quite a troublesome thing. They have frequency, they have incontinence, they have soiling, and they're quite miserable. In a cancer, the patient will accept it because he or she doesn't want recurrence. She doesn't want to die. In a pelvic floor problem, they won't accept morbidity. You won't have to, it's like hiatal surgery or bariatric surgery. They don't accept morbidity. So every patient in our unit who has a LAR or ultra low AR will see my biofeedback therapist, learn those exercises, do it for the 10 days prior to surgery. And we have found that majority of patients have much lesser incidence, or it's quite manageable because we warn them that 30, 40, 50% of you will get these symptoms. This is the medication we'll give you. These are the exercises. See, immediately post-op, they have pain. They can't do the exercises well. So if you have prehabilitated them, as doctor said, it's a useful thing. So it's not an option to surgery. It's always to be done. The only thing, I'm a little desi guy. So we also have a lot of yoga in our, I think some of the yogasanas are excellent. They do pretty much the same thing. These are some of the things that we have learned are extremely effective. We give them we have a YouTube channel. We give them a link and say, do XYZ yogasanas based on your findings. So these are some of our publications on this. But what is the, right. So I believe there are some surgeons who for large piles will do a star operation. Now that is completely illogical. The star operation or the stapled transanal rectal resection must be reserved only for patients of ODS. Large piles are not indications of star. They should be done with PPH, laser, what have you, Milligan-Morgan, but not star. Let's be very clear on that. My gynecologist colleagues tell me we've been doing rectoseals since my residency. I must have done 1,000 transvaginal operations that all do fine. And the problem is when you go back and assess them, ask for a quality of life score in patients who have had transvaginal repairs of rectocele. Not all of them. Maybe a third or 40% of them will do well. But we did telephonic interviews of our own patients. We have a very busy gynae department in our hospital, and almost 1/3 of those patients were taking laxatives or a developed dyspareunia, which they didn't have prior to surgery, and these are not technical issues. Because the reason they got it's like Rupali showed, chicken and egg, what came first? The pelvic floor dysfunction is caused by rectocele. By simply doing the repair like this, you've done nothing to the pelvic floor, and obviously this will manifest in some other way. So in 2015, after coming to Berlin, I thought, the star operation was the next best thing after sliced bread. So I started doing the star operation after learning this. There was a lot of literature. I'm going to keep this short. Extremely good literature showing improvement in Longo scores. So I said, right, the star operation is the answer to these patients, and let's start doing this. Excellent data coming out. And these are all data from the Longo. There are two, if you remember, in Europeans, there are two groups. The Pescatori group, who is anti-star, and the Longo group, which is pro-star. And I was trained by the pro-star group. So I looked at all the references, went and spent 2 weeks, 1 week in Berlin, 1 week in Belgium, and started doing this. And that was the principle of the star. What the star operation did using a circular stapler was to do a circumferential resection of full thickness of rectum and do an anastomosis. But again, the same question remains. What came first? Was it pelvic floor dysfunction causing a rectocele or rectocele causing pelvic floor dysfunction? And that's a question that you can't satisfactorily answer. I'm not going to show you too many videos, but really it can be done by multiple techniques. So we did more than 150 stars in about 10 years. And then those patients started coming back to us for follow-up. Not all of them were happy. Obviously, we were doing Longo scores and Wexner scores pre-op and post-op. We started doing imaging of these patients. So I won't show you the details, nothing great, they are simple techniques. So there are complications. We all know in my own hospital during a live workshop, a very good faculty from outside Mumbai actually created a rectovaginal fistula while doing a star. It's not a theoretical thing. We had to on table do a repair of that. Luckily, the patient did reasonably well. We did just on this is a study until 2022, which we published. I'll show you the publication. Interestingly, in our country, males were more, and I can't explain that because all over the world, females are more. Probably females don't come to us, they go to gynecologists. So it's time that you educate, I was telling Samrat, educate your gynec colleagues. They're the ones who give you the references, they're the ones who've seen these patients. But interestingly, 25% of our patients, 51 out of 190, had previously had a hemorrhoidectomy, fissurectomy, or a fistulectomy with recurrence. So what was happening was the patient was straining, putting a finger in the rectum, bleeding PR, and the fissure or the fistula was repeating. We published our data, the 5-year data, and to me it was quite startling because when we did telephonic interviews at 2 years, this is published in the World Journal of Colorectal Surgery, it was put on the cover page by the journal because it was flying in the face of literature. The literature said the STAR was a great operation. And we were saying that 2 years our success was 92%, which came down to 64% at 5 years. So at 5 years, almost 36% of patients either were using digital maneuvers or using laxatives. That was a disaster. Then the data, more and more data started coming out saying STAR also has problems. So like I said, the final answer to pelvic floor is not here. We need to learn from our mistakes, think about it objectively, look at all the 3 compartments in isolation, and then these are some of the problems that can come after a STAR. Again, going back to patients who have, if you have a solitary compartment, I still maintain if you have a male patient with only a posterior compartment prolapse, I will send that patient for biofeedback, ensure there are no psychological overlay, and if he doesn't improve with biofeedback, I will still offer him the STAR operation. Any patient with 2 or more compartments, you must think about how you're going to manage this because STAR will cause a resection, it will tighten the posterior compartment but not help or worsen the anterior and middle compartment. So then I went to Bristol. In those French in Bristol was a very famous group in UK doing these operations. I spent 2 weeks in Bristol and there was Indian data coming out also, but this is actually how the operation was done. The ventral mesh rectopexy, for some reason in our country, isn't so well established, but this is basically how it's done. It's an excellent operation. We started doing it for these kind of patients. This is the pervaginal finding. These are the MR defibrillar findings, and this is how the operation is done. It's actually a very simple operation, much simpler than a posterior rectopexy. Patient in lithotomy, the first thing I do is sling the uterus to the anterior abdominal wall using a straight needle. I don't use these specialized needles, only rich surgeons like Dr. Jaisingh Shinde in Surya can afford this. I come from a poor city of Mumbai, so we have to make do with jugaad to make sure of what we have. The first step of this operation, and important thing is, remember, these are functional operations. You got to preserve the pelvic nerves. The key here is pelvic nerves. I started doing a modification of the VMR, which I learned in St. Mark's by a guy called Janindra, who is a Sri Lankan surgeon who is a senior consultant in St. Mark's, where you preserve the left lateral ligament dividing the right lateral ligament, and this is the dissection you do. It's important that you completely open the rectovaginal septum all the way down, and the failures of VMR are because you're scared and don't dissect low down enough. So this is the kind of, you must see the levator ani covered with endopelvic fascia on both sides. That is the end point of your dissection. And if it's a male patient, you must go to midway of the seminal vesicles on both sides. I wouldn't do this in a lady below 40 or who is sexually active or who's not had children. But generally, most of these patients are above 50, have finished childbearing, and generally dyspareunia is not such a major issue. So this is how the dissection is done. I'm exposing the endopelvic fascia on both sides, dividing the rectovaginal septum completely, and then I deploy a mesh, a L-shaped mesh from levator to rectum to right levator to the sacral promontory. I'll not show you all the videos. I think I see Jaisingh looking at his watch several times, so I know I must finish on time. But these are the kind of patients that we'll get. You see this lady with full thickness prolapse. The minute I put a speculum in the vagina, the prolapse is getting reduced. So you know that this is a pelvic floor problem. So what I'm doing here is using a Y-shaped mesh. So it's very difficult to handle a Y-shaped mesh. I put 2 pieces of mesh. One mesh goes on the vault, one mesh goes on the rectum, then I stitch this proximally and then take it to the sacral promontory. This is a sacrocolpopexy. These are for tricompartmental prolapses, for patients post-cystectomy walled prolapse as well as rectal prolapse. The problem is if you had come to a surgeon, you would do only rectopexy, a gynecologist would only put it on the vault. So involve your gynecologist if you're not trained in this, but if you have to do something, you must do these kind of operations, which are sacrocolpopexies. And the last thing, obviously, is to completely isolate and shut off the proline mesh by extraperitonealizing the mesh. So these are important. So your pre-op evaluation is extremely important. This is a paper we published in JMAS, I think in 2019, looking at VMR for obstructive defecation, and it's been now almost 4.5 years, and we still have a success rate over 85%. What is success? No digital maneuvers, no laxatives, substantial and objective improvement in Longo score. So far so good, but it's only 4.5 years. So a small modification that I've done for the last 1 year in these patients with pelvic floor descent is to combine a ventral rectopexy with a rectocele repair from below. Those who are very bulky, but I don't have much data on this, I don't want to mention this right now. So what are the considerations for a ventral rectopexy? First is, are you going to use a polypropylene mesh? Because there's a risk of infection and mesh erosion. So we started using macroporous polypropylene meshes. In younger patients who are sexually active, we use a biological mesh, but obviously it's expensive. Dyspareunia has to be mentioned to a patient. I've had one patient, this is what I define by a good outcome after any surgery. 1 to 2 episodes, free of symptoms, ODS score improvement of more than 50%, and 0 digital maneuvers. So these are some of the things that I have had. One patient who came back to me. This patient was operated in South Gujarat, had a posterior rectopexy done, and we had a piece of mesh coming out of the vagina. How it made its way out, she came with a pelvic abscess and sepsis. Initially, we couldn't see this. We drained the abscess, put a pigtail, gave IV antibiotics. On follow-up at about 5 weeks, on a PV, I noticed a foreign body, and then on EUA, we noticed that the proline mesh was coming out through the posterior fornix. So this is extremely important. Not a great deal of long-term data, but this is a nice study from the Italian Society of Colorectal Surgery, and this is also has corroborated our experience, saying that the star and the trans star and the contour trans star, the incidences are gradually going down. Majority of centers are moving to the ventral mesh rectopexy as outside. Now, what do we do with patients who have very large prolapses? Means 5 centimeter rectal prolapse, vault coming out by 3-4 centimeters, and a bladder prolapse. In these patients, even a sacrocolpopexy is not good enough. And there is an operation called a pop star, where you do a star operation for the prolapse, and you put in a mesh extraperitoneal from the ASIS down to the vault. I've only done 3 in the last 5 years that I've started doing this. So far, the results are good, but as I said, for pelvic floor, it has to stand the test of time. 10 years is the minimum when I can say this operation is good. But so far, the pop star may be reserved for these small groups of patients. So what have our learnings been in this time period? The success with star clearly goes down at 5 years. Currently, we use star only for males who have purely posterior compartment rectoceles. Do not use it for pelvic floor descent. Our worst results have been patients where we've done star for pelvic floor descent or those after perineal surgery. Choose your tool appropriately, because as they say, a fool with a tool still remains a fool. Indications of surgery are not very clear. Do not do surgery for anismus, for SRUS, for those who have some overlap of psychological problems, because almost 1/3 of these patients have psychological issues. And perhaps in the years ahead, we will have something like this. There will be a machine learning algorithm. There will be AI, which will, as Sanjay said earlier, the AI tool will tell us this patient should have only biofeedback. He or she should have only surgery. He or she should have a laparoscopic surgery. But that time has not come. This is the data that's coming. So the take-home message, ladies and gentlemen, is it's clearly multifactorial. There is no single answer to these patients. There is an overlap with slow transit constipation and IBS. Never operate on a patient who has IBS or slow transit constipation unless they have pure ODS. It's like hiatus hernia patients. Let the patient earn the operation. If your hiatus hernia patient has upper abdominal bloating, dyspeptic symptoms, gastric emptying issues, never operate on them. They'll never be happy with you. Operate on reflux, let the patient earn the operation. He or she should be PPI responsive. She should have no other symptoms. Similarly, in ODS, he or she should have no slow transit, should have no IBS, should have no supratentorial events, and only operate on these patients. My last word to you is look at the anal sphincter function in order to decide what to do. If your anal sphincter function is not good, do not do any form of transperineal, transvaginal, or transanal surgery. There is enough data that patients may worsen after this. Those who have normal sphincter function as assessed clinically or on manometry, your choice is between doing a star versus doing a ventral rectopexy. This is a pretty busy slide. But clearly, ladies and gentlemen, in all patients of ODS, surgery should always be the last resort. I will not operate on an anatomically significant rectocele or a rectorectal interception unless I am convinced it is only ODS. There are no other things going on. The patient has to complete 3 sittings of biofeedback in my center. Only then I am convinced if they don't improve, then and then only I will offer surgery. So there's enough data that 71% of rectoceles will actually respond to non-surgical management, and I mean rectoceles which don't empty. If you have a 5 centimeter rectocele which is emptying, she will always do well without surgery. Remember, this is something that you must be very careful. And in pelvic floor, as the Lancet said, overcome the instinctive mistrust of the new, yet avoid over-enthusiastic, uncritical adoption of unproven methods. Thank you very much.
Thank you, Roy, for an excellent lecture as usual. So I'll request you to just stay on the stage and you'll be joined with the other panelists and we can have some few questions. Can we have some chairs for the other panelists?
Thank you, sir. Now hall is open for the question and answer session. I'm requesting to all the speakers, please come on the dais for Q&A session.
You come up in the...
You can. Right. So, ladies and gentlemen, you'll agree that we really had an excellent session on pelvic floor disorders, and I'm sure that most of your doubts would have been clear. So, I have few questions for the panelists. My question to Sanjay is that you know that a lot of comorbidities. You see patients who have more than 40, 50, invariably they are hypertensive, they have dyslipidemias and cardiac problem, etc. So they are on beta blockers, they'll be on calcium channel blockers. Some of them might be having anxiety disorders, so they would be an antidepressant. And they are constipated. You cannot stop these medicines. These medicines are essential for their life. So what are you going to do for these? Oh.
I suppose whatever you have to accept, you have to accept.
Yeah.
But then it's very likely that whatever solution you're going to give them, you may not be able to. So the whole thing was that I wanted to, most guidelines say that you can continue medication till 6 months.
Right.
Trials are done to 6 months and nothing is beyond. No one wants to say anything, but the problem is going to last him a lifeline.
Right.
So, we always need to say something about how to stop.
Yes.
And that was best given by the NHS. The patient should try to de-escalate.
Correct.
So he'll have to identify along the way how best he can de-escalate and go off medication which is more habit forming.
Yeah, but here is what the reality is, that when the patient tries to de-escalate, they stop the allopathic medicine and shift to Ayurvedic medicine, to the churn which you said. And they'll end up in much more problems after that, The constipation worsens, so every time they have to go on escalating the dose, So
I thought that the biggest message I got from the NHS was that differentiate between the lesser medication first.
Right.
That means, if you're using polyethylene glycol and lactulose,
Yes.
you have one of that and one which is secretory.
Right.
So try to focus on the one which is, the secretory one, try to get it off. Yeah. At that time, escalate the peg or escalate the lactulose
Right.
so that you can do away with it. So at least you know your benchmarks. And then from there, it's going to be up and down, up and down.
Yes.
But it has to be done that way. You cannot switch off and taper.
Yes.
Tapering is probably not going to work for them. That's the message I got from that NHS.
And I think many times a combination laxative therapy helps in these patients because
and then we have to give them something for rescue.
yes.
So they have to have something on a day when it doesn't happen.
Right. And now one of the more very common prescription which I see from the physician and the patients are constipated, they add all their medicine and at the end of it they write Cremefen. And the physicians, patient are going to be with them for years together, So they go on taking Cremefen for years together and they land up with various deficiencies. One of the side effect of Cremefen being a mineral oil, it causes coating in the terminal ileum and they'll land up with vitamin B12 deficiency. So they'll be put on vitamin B12 injection. They'll develop vitamin D deficiency. So they'll be put on vitamin D, etc. All these things. So all the medication go on increasing. So I think we also have to keep this in mind that Cremefen is one of the agent which should not be taken on a very long-term basis. So now my question to Dr. Darshan is that you gave a very nice lecture overview on MRD. What would you do if your patient comes to you for MRD but has claustrophobia? Because in other cases, we might give a sedative, we might give him something, sleeping medicine and do a MRD. But here we require patient's cooperation.
So claustrophobia is not a very big issue for MRA because we can put the patient feet first.
It is. I myself am tremendously claustrophobic. I cannot enter into a MRI machine.
So we can put the patient feet first so that the head and the face, it remains outside the MR gantry.
Okay.
That can be taken off very well. Other very simple option is what you can do. You can blindfold the patient outside the MR gantry itself.
Okay.
That is a very simple option and this was suggested to us by one of the patients itself.
Okay.
So you blindfold the patient outside the MR gantry.
Right.
The patient has headphones and they are able to listen to instructions what you are given to the patients. Very, very simple and it's a proven technique.
But if a patient is a doctor, he knows what MRI is.
Then God save that patient, sir.
Pradeep, you need a MRD, I think, the way you're asking these questions.
Yeah. My question to Roy is that I know how you have changed over a period of time because I saw that your background of your slide has also become more jazzy today. Yeah. So my question is that you showed one maneuver of showing the prolapse, putting a dry gauze piece inside, pulling it out. If suppose it shows a prolapse, are you going to change your procedure? What
No,
you are
I'm
going
not.
to?
On table, you can't consent patient
Correct,
to change your
exactly.
operation.
Yes.
At least you know that something has gone wrong. You can counsel the patient that you need biofeedback post-op. We'll reassess you at 3 months with a MRD. You may need a second procedure. At least that is something worth doing.
Right, because this is where Dr. Longo advises doing a star operation for him, right, rather than a MIPH.
You're provoking me, but I won't fall for that.
I know, yeah, right. And I think another one more good point which you said is that we have to always corroborate the clinical finding with the MRD finding, because if they don't match, don't go in for that procedure. If because I've seen some patients, they have big cystocele, you do a MRD, you find big cystocele, but they don't have any urinary complaints. So don't fall for doing a antiacolporaphy or repairing the cystocele. I think we should be going in for what the patient came for. This is a benign condition. This is not a malignant condition. So what the patient came for, I think we have to treat that symptomatology.
Similarly, rectoceles can be physiological.
Yes.
Don't operate on every rectocele that you see.
Absolutely.
Unless it correlates with ODS.
Yeah.
Similarly, your MRD in almost 5 to 10% of patients does not correlate with clinical findings.
Yes.
So be careful. I think it's multifactorial. No one test is the gold standard. You need to combine all of this, but primary is your finger.
Correct. So this is one philosophy of pelvic organ prolapses, that we have to go by the symptomatology of the patient and not entirely by the finding which are there on MR defecography. You spoke about your STAR result, which were excellent but deteriorated over a period of time. I am also of the same opinion, because I feel that in STAR we just resect the tissue and we repair it. So it's like, in hernia, you are just doing an anatomical repair and you know that this is going to break off or this is going to give way over a period of time. So I think STAR really doesn't strengthen the rectovaginal septum, the degenerated rectovaginal septum, which is there between the rectum and the vagina. And I think probably that's the reason why the result of STAR, they go on going down and down. Success goes on.
So Dr.
going
Rupali
down.
showed
Yeah.
the chicken and egg. I
Correct.
think that's a very good analogy for this. So when you do a STAR, make sure you give them prehabilitation,
Yes.
look at diet, look at laxatives and continue that post-op.
Yes.
And yet I think for male patients, a good number of them will do well if they have unicompartmental posterior compartment prolapse.
Yes. In fact, in many of these rectocele, especially the female patient who has a rectocele, a large rectocele, I would prefer doing a transperineal repair and putting a biological mesh in between to strengthen the rectovaginal septum rather than just resecting it by doing a STAR repair. My next question to Dr. Rupali is that you have subjected your patient to biofeedback, patient improves, comes to you after 1 year, 2 years with again the same symptom. Are you again going to subject him to biofeedback or refer him to surgery, or what are you going to do? What's going to be your approach?
First of all, we can ask him how nicely he has practiced it at home.
Right.
If he has really practiced it for suppose for 6 months and then he has given up, then we can give him one reinforcement session. If he really improves, then it's well and good. And if he's not improving, then we can think for that.
Okay, would you advise yoga therapy for this? Because that's something which a patient
Yes,
himself can do at home.
Yeah, I have shown that some of the yoga poses.
Yes.
So we have to advise them the yoga poses plus
Right.
the core exercises also.
Right.
So which will help or add the result of the biofeedback.
Right, yeah. Yeah,
Pradeep, on a little more humorous side,
Yes.
one of my एक गावाकडला पेशंट होता
right.
आणि तो म्हणला अरे डॉक्टर एवढे पैसे घेतले हागायचं कसं शिकवलं I had no answer to that.
You can say that the money has gone in the drain.
It is actually that I many times tell patient or to the non-medicals like what I do. So I say that I teach the patient how to go to the floor and
to
how
shit.
to do it properly.
आता लोकांना ते पण शिकवावं लागतं आपल्याला.
Yes. Because of maybe the changed lifestyle, this is really increasing more.
Right. My next question to Dr. Dipti is that a patient has no organic problem, it's a functional problem. So whether biofeedback or physiotherapy,
Actually,
which one first?
so that depends on the nature of the condition. Like I said, we also do biofeedback, but we do electrical biofeedback.
Yes, yes. That's
So-
why I'm asking you why, whether means I'm in a hospital where both are available. So first biofeedback or first physiotherapy, and why?
So physiotherapy is also like I was saying, if it is more of a structural issue, like the support is not there and the
Right.
condition is being caused, like for example, a prolapse or a rectocele, which you want to,
Right.
like a grade 2 rectocele, and you're thinking you're not going to operate on it,
Right.
then more than biofeedback, you would want to try stimulation because this is a non-functional floor.
Yes.
But if it is a rigid floor or it is a spastic floor and you want relaxation first, I would go for biofeedback first. So it all depends on whether, like I said, you want to uptrain or downtrain. Usually downtraining, we take biofeedback first because the
Okay.
focus is on relaxation. Uptraining, you would go for strengthening first. So more for traditional physiotherapy.
Okay. And we see so many MRDs. One of the thing mentioned is the mild pelvic descent. So are they candidates for biofeedback or for physio?
Both, sir. See, biofeedback is actually retraining how you use your pelvic floor muscle. So it's
Okay.
more of a retraining. We're not strengthening it. So
Okay.
first you retrain them how to use the correct floor, correct muscles to defecate. Also the correct muscles not to strain. What are you doing wrong? So if you're still going to strengthen the floor and use intra-abdominal pressure, that is not going to help. So it kind of goes hand in hand because then you're now using you have to teach them to do the diaphragmatic breathing. You have to teach them not to use intra-abdominal pressure. How do you squeeze through the rectum or, use defecatory postures? If you have any pain, release that. Then do biofeedback again. So
Okay.
that is how. So they kind of go hand in hand. It's
Okay.
really hard to differentiate.
Dr. Rupali, would you like to comment on this?
uh, like as a biofeedback expert, if it is dyssynergic defecation and no other components are involved and the strength, like what she has explained, if the strength of the muscle is nicely intact and it's there and patient is able to understand, then we can go for biofeedback.
Okay.
But if the strength of the muscle is the issue, I'm not able to see any change on the tracing about the external anal sphincter movement, then it become little difficult to just focus here. So if the strength is improved, we can go for the biofeedback, but that is intact, then better we can go for biofeedback first.
Mild perineal descent means the muscles are weak.
Yeah.
That means that the muscles are weak, perineal support is weak. So how are you going to assess whether muscles are strong or muscles are weak?
That will, the tracing gives us the everything, we get the
Okay.
parameters, yes. The anal manometry basically gives us the real, the pressure parameters, pressure changes, so that everything we will get, internal anal sphincter, external anal sphincter, pressure we get. So depending on, we can think.
No, but pelvic descent is not because of the sphincter. Pelvic descent is because of the iliococcygeus, ischiococcygis, and those muscles being the levator ani being weak,
So this is where reinforcement will work, sir.
Yeah.
So defecatory mechanics. So
Okay.
it is initially hard, but once you correct the mechanics and you tell them not to, it has to heal organically. If this is a patient you have decided not to operate on, it is
Right.
not significant enough to operate, now it requires time for those muscles to regain their elasticity. So you are training them to get stronger in adjacent to telling the patient not to strain.
Okay.
So also you're contracting. So we teach them, let's, for example, what would be the thing which would make the descent even worse? So when you're pushing or you're pulling.
Okay.
So you teach them to hold their pelvic floor muscles when they're working out, when they're doing an aerobic activity. So if you've decided, the surgeon says this is not significant enough, so now we are either maintaining it because we cannot strengthen it overnight.
Right.
So we keep track of how much the descent it and hopefully arrest it at where it is and not let it become worse because of chronic constipation again.
Okay. One more question I want to ask. You mentioned about the electrostimulation. So are you doing it through needle electrode or by percutaneous?
No, sir. No, we do not use needle electrodes here. Yet I think that's a procedure. I have not used it in a therapy setting. Usually that's done in a theater.
Yes.
But we use the anal electrodes,
Yes.
different sizes for different patients.
Okay.
And we use the same electrical VMS stimulation you use for a facial palsy or any kind of muscular stimulation.
So it is
Same
just
kind of-
passed per anally.
Yes, sir.
per
Yes, sir.
anally.
So it takes a little time for the patient to get used to it. It's not troublesome. It is not painful at all, but it just takes a little getting used to. So it's the same thing like you get for a neck pain or a back pain, but we start with a slower current. And as the patient starts getting a stronger contraction, the sensation of discomfort also goes away.
Okay. Because the same thing with sacral nerve, SNS also, sacral nerve stimulation.
Sacral nerve
also.
is different,
That is also, you have to implant the electrode percutaneously. You might have to put an implant also, implantable battery inside, etc. That's a
That is
surgical
more of a
procedure.
surgical procedure.
Surgical
sir.
procedure,
Yes, that's a
right.
surgical procedure.
Yeah.
So we are doing the non-invasive part of it.
Posterior tibial. You are
So
doing
we
the
are doing
posterior tibial.
we are doing an external. We are doing an external electrode. So this works actually really well when when we are trying to correct the urge. So the
Yes.
patient is saying, I have incomplete evacuation, but we know for a fact that there is nothing in there. The compartment is empty. So we
Yes.
try to calm the urge by giving a tense stimulation to S1, S2. The difference is it's like, it is dependent on the patient's habits also. But percutaneously or S1, at the posterior tibial or S1, S2, we use external electrodes only. We don't use needle electrodes.
Yes, I think the literature also mentioned the same thing, that the result of posterior tibial are quite good and quite comparable to, right.
So just for matter of time, we might take a couple of more questions
Yeah.
and then we have dinner and we can connect with the speakers along with our dinner if that's okay.
If Dr. Bharat has any
So we'll
questions.
just,
This question is about evolution of pelvic floor disorder. How retrogradely, how long you can say that the changes have been occurring? Like, can it be attributed to faulty toilet training in the childhood? Or like cancer, we know it's 5 years to require from 1 cell to 1 centimeter tumor. How long these changes would be happening in the body to manifest as symptomatic problem?
The easiest answer to this question is some people get dysenergic defecation after an episiotomy. This is the clearest indication of patients coming with recent onset constipation. Episiotomy झाली, after that symptoms of constipation evolved. The next indication which I see very commonly is heart मध्ये stent पडला. Doctor said don't strain. Defecation disorder started. So there are people walking around us who get dysenergic defecation purely because of how they adapt to the advice that we are giving them. So things are happening all the in each age group. You know, withholding behavior is described in children. They get perineal pain, they don't want to defecate, they withhold, and they start getting encopresis. So this is, I mean, we can go on and on.
I think problem with the school. They might have some problem in the school with their teachers or something like that, and that also reflects into their defecatory habits. This is very common in children. Yeah.
You know, Pradeep, another important group, Pradeep, is patients who have severe anal pain. You do a per-rectal proctoscopy examination is normal, colonoscopy is normal. Invariably, they are labeled psychological. And this is so-called trigger point pain. It's usually specific to one area, and it's almost always pelvic floor dysfunction. I've had a MD medicine of Pune who had a laser sphincterotomy done by a famous proctologist of Pune for this pain, and obviously the pain continued. And so this is extremely important, and you can usually identify. What I tend to do is it has to be localized to a particular point, and this patient only had a paradoxical puborectalis. You do a PR and push downward, you can feel a taut puborectalis which causes tenderness, pretty much mimics the pain that he or she is getting. So every patient you can't diagnose is not necessarily mad. Maybe it's something you don't know also.
So you Botox that patient? Yeah. Right.
So this is an amazing session. So I thank all the faculty here, everyone who has been so patient. So I think we all will agree that we have learned a lot. They all have been so methodical, so detailed, and so informative. Certainly I have learned a lot of things today. So thank you. A big clap of hands for all the speakers. You all have been amazing audience. So thank you for bearing with us. This is, I know this is very late, so we are going to open the floor for dinner. But before that, we're just going to have a quick felicitation of all our speakers, if you allow us. So I'm just going to start with, so Dr. Samrat to come over, just to felicitate our speakers.
My only suggestion is next time don't have it on a dry day.
We'll have to change the location as well. Tip Top doesn't allow non-vegetarian or drinks. So we'll start in the same hierarchy as we started the talks. So, Dr. Sanjay. So, Dr. Sanjay Salanke. Yeah. Salanke sir is an inspiration. Your clarity of thoughts and your 10 commandments are certainly going to serve us well. Thank you so much. Dr. Darshan. Dr. Darshan, again, your MRI information and everything is going to help us see the patient clinically in our OPDs. Dr. Dipti. Dr. Dipti has traveled all the way from Hyderabad, so we are very grateful for all the insight that you have given into the pelvic physiotherapy and all. So thank you so much. Lastly, but not the least, Dr. Roy Patanka. He has traveled all the way from Mumbai, and we are very grateful for that. Now, lastly, I would love to invite our chairpersons, Dr. Pradeep Sharma and Dr. Bharat Dixit. Please, if you could join us on the dais, please. So, as moderators, these guys are very well used to doing this stuff. And we at Kaizen family are very privileged to have them as our moderators. Thank you very much. So, yeah. So we'll just take, yeah, please come, please come. So we're just going to take a photo. And we'll open the dinner. So thank you all. Thank you all the delegates. We would request everyone to please have dinner and enjoy the evening. Thank you.